The Committee on Public Health will come to order. Clerk will call the roll.
Chairman Van Dever.
Present.
Vice Chair Campos.
Present.
Busey. Collier. Cunningham. Frank. Johnson. Jones.
Here.
Olcott.
Here.
Pearson. Schofield.
Here.
Schaffner.
Here.
Simmons.
Here. Johnson.
Oh, Johnson. A quorum.
A quorum is present. We will be taking public testimony today. If you are here and planning to testify on any of the bills on today's agenda, please make sure you have filled out the electronic witness affirmation form on the registration, the electronic registration on the kiosk out in the hallways. We will be limiting public testimony to 2 minutes, and I ask that you please adhere to that. I'm not a mean guy, but I do still have a teacher voice, and we will use it as necessary to stop you at 2 minutes. So please be aware of that and just be courteous to those who are coming after you. We do have an overflow room. It is in E2036. If you would like to go there, there will be places to sit there, and you can follow the meeting and then come back as you need to. Members, we are going to begin this morning by voting some bills out. I think you have already received a list of those. So Chair recalls House Bill 3269 from subcommittee. Chair lays out House Bill 3269. Chair lays out a complete substitute. Members, House Bill 3269 is Chairman Guillen's bill to establish the Rita Littlefield Chronic Kidney Disease Centralized Resource Center. The committee substitute is alleged council draft. Is there objection to the adoption of the committee substitute? Chair hears none. Substitute is adopted. Chair moves that HB 3269 as substituted be reported favorably to the full House with recommendation that it do pass and be printed. Clerk will call the roll.
Chairman Van Dever.
Aye.
Vice Chair Campos.
Aye.
Busey. Collier. Cunningham.
No.
Frank.
Aye.
Johnson.
Yes.
Jones.
Aye.
Olcott.
Aye.
Pearson.
No.
Schofield. Schaffner.
No.
Simmons.
Aye.
There being 8 ayes, 4 nays, motion prevails. Chair lays out House Bill 2587 as pending business. Chair lays out a complete committee substitute. Members, House Bill 2587 is Representative Alcott's bill, which would require any hospital in this state that provides uncompensated care to include their patient intake form a questionnaire about the patient's immigration status. The committee substitute adds conforming changes to more closely align the bill to Executive Order 46 and the execution of the order by Health and Human Services Commission. Is there an objection to the adoption of the committee substitute? Chair hears none. Substitute is adopted. Chair moves that House Bill 2587 as substituted be reported favorably to the full House with recommendation that it do pass and be printed. Clerk will call the roll.
Chairman Van Dever.
Aye.
Vice Chair Campos.
No.
Busey. Collier. Cunningham.
Yes.
Frank.
Yes.
Johnson.
No.
Jones.
No.
Olcott.
Aye.
Pearson.
Aye.
Schofield.
Aye.
Schaffner.
Aye.
Simmons.
No.
There being 7 ayes, 5 nays, motion prevails. Chair lays out House Bill 4070. Members, House Bill 4070 is Representative Johnson's bill, which classifies orthodontic devices as a medical device regulated by Chapter 431 of the Health and Human Safety Code. Chair moves that House Bill 4070 as filed be reported favorably to the full House with recommendation that it do pass and be printed. Clerk will call the roll.
Chairman Van Dever.
Aye.
Vice Chair Campos.
Aye.
Busey. Collier. Cunningham.
Yes.
Frank.
No.
Johnson.
Yes.
Jones.
Yes.
Olcott.
Aye.
Pearson.
No.
Schofield. Schaffner.
Aye.
Simmons.
Aye.
There being 9 ayes, 3 nays, motion prevails. Chair lays out House Bill 5141 as pending business. Chair lays out a complete committee substitute. Members, House Bill 5141 is Representative Howard's bill, which authorizes the Department of State Health Services to lease certain property in Travis County. Committee substitute changes DSHS to HHSC. Is there objection to the adoption of the committee substitute? Chair hears none. The motion prevails. Chair moves that House Bill 5141 as substituted be reported favorably to the full House with a recommendation that it do pass and be printed. Clerk will call the roll.
Chairman Van Dever.
Aye.
Vice Chair Campos.
Aye.
Busey.
Aye.
Collier. Cunningham.
Yes.
Frank.
Aye.
Johnson.
Yes.
Jones.
Yes.
Olcott.
Aye.
Pearson.
Aye.
Schofield.
Aye.
Schaffner.
Aye.
Simmons.
Aye.
There being 12 ayes, 0 nays, motion prevails. Chair lays out House Bill 2188 as pending business. Members, House Bill 2188 is Representative Howard's bill, which would direct the Health and Human Services Commission and the Board of Nursing to create an operational plan to transition the Certified Nurse Aide Certification Program from HHSC to the Board of Nursing. Chair moves that House Bill 2188 as filed be reported favorably to the full House with a recommendation that it do pass and be printed. Clerk will call the roll.
Chairman Van Dever.
Aye.
Vice Chair Campos.
Aye.
Busey.
Aye.
Collier. Cunningham.
Yes.
Frank.
Aye.
Johnson.
Yes.
Jones.
Aye.
Olcott.
Aye.
Pearson.
Aye.
Schofield.
Aye.
Schaffner.
Aye.
Simmons.
Aye.
There being 12 ayes, 0 nays, motion prevails. Chair lays out House Bill 1431 as pending business. Chair lays out a complete committee substitute. Members, House Bill 1431 is Representative Gertie's bill, which sought to ban the manufacture and production of cell-cultured protein to ensure consumer safety while maintaining the integrity of traditionally raised proteins. The changes to the newest committee substitute include a new bill caption and a prohibition on the offering of cell and the sale of cell-cultured protein for human consumption. The prohibition on the offering of cell for human consumption expires September 1st, 2027. Removal of the higher education exception that was in the previous committee substitute. Is there objection to the adoption of the committee substitute? Chair hears none. Substitute is adopted. Chair moves that House Bill 1431 as substituted be reported favorably to the full House with a recommendation that it do pass and be printed. Clerk will call the roll.
Chairman Van Dever.
Aye.
Vice Chair Campos.
No.
Busey.
No.
Collier. Cunningham.
Aye.
Frank.
Aye.
Johnson. Jones.
Nay.
Olcott.
Aye.
Pearson.
Aye.
Schofield.
Aye.
Schaffner.
Aye.
Simmons.
There being 8 ayes, 3 nays, motion prevails. Chair lays out House Bill 3829 as pending business. Members, House Bill 3829 is Representative Curry's bill, which directs the Department of State Health Services in collaboration with the Texas Humane Legislation Network to conduct a study on the grant process of organizations receiving funds from the Animal Friendly account. Chair moves that House Bill 3829 as filed be reported favorably to the full House with a recommendation that it do pass and be printed. Clerk will call the roll.
Chairman Van Dever.
Aye.
Vice Chair Campos.
Aye.
Busey. Collier. Cunningham.
Aye.
Frank.
Aye.
Johnson. Jones.
Aye.
Olcott.
Aye.
Pearson.
Aye.
Schofield.
Schofield.
Aye.
Schaffner.
Aye.
Simmons.
Aye.
Johnson.
Yes.
There being 12 ayes, 0 nays, motion prevails. Chair lays out House Bill 2200 as pending business. Members, House Bill 2200 is Representative Hernandez's bill, which seeks to include natural organic reduction as a permissible way of disposition under Texas law. The chair moves that House Bill 2200, as filed, be reported favorably to the full House with a recommendation that it do pass and be printed. Clerk will call the roll.
Chairman Van Dever.
Aye.
Vice Chair Campos.
Aye.
Busey.
Aye.
Collier. Cunningham.
No.
Frank.
No.
Johnson.
Yes.
Jones.
Aye.
Olcott.
Nay.
Pearson.
No.
Schofield.
Aye.
Schaffner.
Nay.
Simmons.
Aye.
There being 7 ayes, 5 nays, motion prevails. Chair lays out House Bill 3219 as pending business. Chair lays out a complete committee substitute. Members, House Bill 3219 is Representative Schaffner's bill, which would authorize a licensed pharmacist to dispense ivermectin statewide without a healthcare practitioner's prescription. Committee substitute adds liability protection for the Commissioner of the Department of State Health Services. Is there objection to the adoption of the committee substitute? Chair hears none. Substitute is adopted. Chair moves House Bill 3219 as substituted be reported favorably to the full House with a recommendation that it do pass and be printed. Clerk will call the roll.
Chairman Vandever.
Aye.
Vice Chair Campos.
Aye.
Busey. Collier. Come back to her.
Yeah.
Cunningham.
Yes.
Frank.
Aye.
Johnson. Jones.
Nay.
Olcott. Pearson. Schofield. Schaffner. Simmons. And then- Yeah. she- I- yes. Do you want-
Let the record show Representative Collier present.
Nay.
Or Collier?
Nay. Oh, sorry.
Okay.
There being 8 ayes, 5 nays, motion prevails. Chair lays out House Bill 4882 as pending business. Chair lays out a complete committee substitute. Members, House Bill 4882 would require birthing facilities to perform a congenital cytomegalovirus test on each newborn before the newborn is discharged from the facility. Committee substitute removes a conflicting provision from the Health and Safety Code. This provision still allowed for the testing to be optional and would have created ambiguity between the proposed change. Is there objection to the adoption of the committee substitute? Chair hears none. Substitute is adopted. Chair moves House Bill 4882 as substituted to be reported favorably to the full House with the recommendation that it do pass and be printed. Clerk will call the roll.
Chairman Vandever.
Aye.
Vice Chair Campos.
Aye.
Busey. Collier.
Aye.
Cunningham.
Aye.
Frank.
Aye.
Johnson.
Yes.
Jones.
Aye.
Olcott. Pearson.
Aye.
Schofield. Schaffner.
Aye.
Simmons.
Aye.
There being 13 ayes, 0 nays, motion prevails. Chair lays out House Bill 3785 as pending business. Chair lays out a complete committee substitute. Members, House Bill 3785 is Representative Gervin Hawkins' bill, which seeks to establish parity between traditional and compounding pharmacies by implementing and enforcing clear, standardized regulatory guidelines. The committee substitute language removes the word furnishing and keeps the word dispense. Substitute language clarifies distinction between label and labeling and removes the word substitute. Also removes the word amount and inserts the word volume. Is there objection to adoption of the committee substitute? Chair hears none. Substitute is adopted. Chair moves House Bill 3785 as substituted to be reported favorably to the full House with the recommendation that it do pass and be printed. Clerk will call the roll.
Chairman Vandever.
Aye.
Vice Chair Campos.
Aye.
Busey.
Aye.
Collier.
Aye.
Cunningham.
No.
Frank.
No.
Johnson. Jones.
Aye.
Olcott.
Nay.
Pearson.
No.
Schofield. Schaffner.
No.
Simmons.
Aye.
Okay, there being 6 ayes, 6 nays, the motion does not prevail. Chair lays out House Bill 1621 as pending business. Chair lays out a complete committee substitute. Members, House Bill 1621 seeks to amend Chapter A, Subchapter A, Chapter 1001 of the Health Safety Code to require Health and Human Services Commission to establish a state-administered matching grant program to support technological modernization at hospitals providing mental health care services. Is there objection to the adoption of the committee substitute? Chair hears none. Substitute is adopted. Chair moves that House Bill 1621 as substituted be reported favorably to the full House with the recommendation that it do pass and be printed. Clerk will call the roll.
Chairman Vandever.
Aye.
Vice Chair Campos.
Aye.
Busey.
Aye.
Collier.
Aye.
Cunningham.
Aye.
Frank.
Aye.
Johnson.
Yes.
Okay, Jones.
Aye.
Olcott. Pearson.
Aye.
Schofield. Schaffner.
Aye.
Simmons.
There being 11 ayes, 1 nay, motion prevails. Chair lays out House Bill 1747 as pending business. Members, House Bill 1747 is Vice Chair Compos's bill, which will amend the government code to establish the Mental Health, Substance Use, and Public Health Initiative Council to ensure that money allocated to the Mental Health, Substance Use, and Public Health Initiative Trust Fund is allocated fairly and spent to improve the coordination among mental health, substance use, and public health. Chair moves that House Bill 1747 as filed be reported favorably to the full House with a recommendation that it do pass and be printed. Clerk will call the roll.
Chairman Vandever.
Aye.
Vice Chair Campos.
Aye.
Busey. Collier.
Aye.
Cunningham.
Aye.
Frank.
Aye.
Johnson.
Yes.
Jones.
Aye.
Olcott. Pearson. Schofield. Schaffner.
No.
Simmons.
Aye.
There being 10 ayes, 3 nays, motion prevails.
No. Let's do Harless. Let's see. Okay. Now. 3540.
Chair lays out House Bill 3540. Chair lays out a complete committee substitute. Chair recognizes Representative Harless to explain the bill.
Thank you, Mr. Chairman and members. The committee sub for House Bill 3540. Members, before you today is a committee substitute that is agreed to by the Pediatric Society, All Pharmacy, the Texas Medical Association, and after many sessions of this issue coming before this body, a compromise has been reached. I'd like to first say that this bill is just about access for families that choose to vaccinate their children. Following the expiration of the Federal Public Readiness and Emergency Preparedness Act, Texas pharmacists cannot, without a physician's protocol or standing orders, administer vaccines to patients under the age of 14, or administer flu vaccines to patients under the age of 7. The ability to obtain immunization and vaccinations is critical for families that choose to get them, especially for rural Texans who experience an increasing lack of constant and ample access to physicians. The committee sub for House Bill 3540 would expand pharmacists' vaccination and immunization authority to allow them to service patients age 5 and up with all approved and authorized vaccines, and they could service patients 3 and up with flu and COVID. This bill would also require pharmacists to provide notice of vaccination to a patient's physician within 3 business days with a recording of the vaccination in the state-maintained immunization registry serving as notice. This bill would also require pharmacists to inform patients and adult caregivers of the importance of an annual well child visit with a pediatrician or primary care provider to help ensure that we're still promoting doctor visits and letting patients know that pharmacy visits don't take the place of an annual checkup. Finally, this bill would allow pharmacy technicians who possess the necessary education and certification to administer the vaccines, but it would not allow a pharmacy tech to order them. This substitute has been worked on by both the pharmacist and the pediatrician to help get it to a place where it's acceptable by both sides. And the point of this is simply to expand access to vaccines and immunization. It does not take place of a doctor visit, and it certainly does not mandate vaccinations. With that, I believe I have some people here that will be happy to answer any questions, and I respectfully ask for the opportunity to close.
Okay, members, any questions? Okay, we will give you your
Thank you.
opportunity to close. Chair calls Michelle Evans, Renan Ching, Dr. Jason Turk, and Amy Lusson. I have Renan Ching testifying on behalf of Texas Pharmacy Association and self, and you are for House Bill 3540. Is that correct?
That's correct.
Thank you. You may proceed.
Thank you. Good morning, Chairman Van Dever and members of the House Public Health Committee. My name is Raymond Ching, and I'm an independent pharmacist that runs a Tarrytown Pharmacy, a small business pharmacy here in Austin, Texas. I appreciate the opportunity to testify today in support of HB 3540, the compromise offered by Representative Harless. I represent myself in the Texas Pharmacy Association. When COVID-19 shut down brick and mortar medical offices in 2020, grocery stores and pharmacies were essential. When vaccinations became available, pharmacists, who have been providing vaccines for 26 years, stood ready to become the first-line providers to people in nursing homes, at mass immunization events, and when more vaccines were available, at our own pharmacies as well. Some of the vaccines were required to be stored in ultra-cold freezer with temperatures between -130 and -76 degrees Fahrenheit, which we had. We were open daily to serve families in our community with our full pharmacy and immunization services. We traveled throughout the state to provide vaccines to intellectually disabled patients and their nursing homes and families, where patients were in rural areas not able to easily go into the pharmacy in person. And even before the pandemic hit, Tarrytown Pharmacy had already been administering immunizations and vaccines to children for many years with a direct prescription from their physician. And this experience really provided us with the confidence and expertise to assist pediatricians and the local health departments to serve families throughout the state. We had many families come in with children, parents, and grandparents to get all their vaccinations as a group as well. So the patients in our community rely on Tarrytown Pharmacy for immunization and vaccines because we're open 7 days a week and open till 8 p.m. on most days. A lot of the families that we serve have parents that work during the day, and they seek services in the evenings and weekends after they get off work. We also work closely with physicians and pediatricians in our area to provide complementary health services to our patients. And pharmacies across the state have similar stories to us and ours as well, and they are the front door to healthcare. We provide convenient access to care as a partner in the healthcare team, and we're committed to improving public health. Under the PrEP Act, pharmacy technicians were also permitted to and trained to administer vaccines, and this bill would provide state authority for PrEP Act immunization authority to continue. So we urge the support of HB 3540, the compromise offered by Representative Harless.
Thank you. Chair recognizes Michelle Evans, testifying on behalf of Texans for Vaccine Choice and self against House Bill 3540. Is that correct?
That is correct.
Thank you. You may
Thank
proceed.
you. Good morning, Chairman Van Dever, Vice Chair Campos, and committee members. My name is Michelle Evans. I'm the Political Director for Texans for Vaccine Choice. I'm here on behalf of myself and that organization to testify against HB 3540. To be clear, TFVC does not oppose safe access to vaccines. We support maintaining necessary guardrails, recognizing that the third leading cause of death is medical error, defined as caused by inadequately skilled staff, error in judgment or care, system defect, or preventable adverse effect. The changes in the domain of care for pharmacists and pharmacy techs created under the PrEP Act were done so in response to a recognized public health declaration and were narrowly applied to COVID-19 only. This declaration has since ended, and a subsequent emergency does not exist to justify making these changes permanent nor broaden them. TFVC sought the insight and advice of practicing pharmacists in reviewing this bill, and they expressed deep apprehension. They have very specific limited duties which prevent them from transgressing upon responsibilities typically designated to physicians. Their training and education is specifically crafted for the practice of dispensing, not practicing medicine. Providing vaccines for children as young as 3 or 5 requires specific knowledge in developing organ systems and should involve a familiarity with the patient's unique medical and family history. These are crucial in determining susceptibility to reactions, medical necessity of the vaccination, and whether precautionary measures should be taken before, during, or after the vaccination. Without supplemental formal education and a prerequisite for having a documented, established relationship with the patient, HB 3540 fails to ensure patient safety. An additional concern is that the reporting period during which the pharmacist is expected to notify a physician has been significantly extended now to 3 days from 24 hours, a period during which the patient could experience life-threatening adverse reactions that are not properly diagnosed or treated. In short, it is in the best interest of all patients that any medical procedure they undergo is done so under the supervision of a healthcare provider who has more in-depth knowledge of...
Thank you for your testimony.
Appreciate it.
Chair recognizes Dr. Jason Turk. I have you listed as testifying on behalf of Texas Medical Association, Texas Pediatric Society, and yourself, and you're for House Bill 3541. Is that correct?
That is correct, Chair
Thank
Van
you.
Dever.
You may proceed.
Chair Van Dever, Vice Chair Campos, and committee members, I am Dr. Jason Turk, a pediatrician practicing in Keller, and I'm representing the Texas Medical Association and the Texas Pediatric Society. We appreciate the opportunity to testify in support of House Bill 3540. First, our organizations would like to thank Chair Harless for his dedication to child health and willingness to work with us to find common ground on this historically contentious issue. We wholeheartedly agree that ensuring access to timely vaccination is key to preventing the spread of vaccine-preventable illness, such as what we are seeing right now. We also appreciate the attentiveness to promoting the pediatric medical home and ensuring children have access to a full range of preventive health care services present in the well child exam. This compromise legislation strikes a fine balance between those two priorities, which has brought TMA and TPS to support this bill. By bringing the age of vaccination of pharmacists down to the age of 5, we allow families to benefit from some convenience and access while they benefit from during the public health emergency, while still ensuring that our youngest patients are coming into the medical home for vaccinations, developmental screenings, anticipatory guidance, and many more preventive health care services that I provide every day in my clinic. Additionally, this legislation will ensure that when a child receives a vaccination at a pharmacy, that the medical home is notified within 3 days so that we can ensure that ongoing collaboration and coordination between healthcare settings occur. Finally, we want to thank all the stakeholders involved for their intention to look at ways to bolster participation in the Vaccines for Children program so that all children can benefit from increased access to vaccination. And we sincerely hope that further negotiations on this contentious issue are not needed in the foreseeable future. We thank Chair Harless for his efforts, and thank you to the committee members for your time.
Thank you for your testimony. Chair recognizes Amy Lusson. Have you registered as testifying on behalf of Texas Federation of Drugstores and Walgreens and yourself, and you are for House Bill 3540. Is that correct?
That's correct.
Thank you. You may proceed.
Good morning, Chairman Van Dever and members. Thank you for the opportunity to speak today. My name is Amy Lesson, and I'm a licensed pharmacist in Texas and Director of Pharmacy and Retail Operations for Walgreens. I'm also currently the President of the Texas Federation of Drugstores. I want to sincerely thank Representative Harless for the thoughtful dialogue of bringing pharmacists and physicians together to find a true compromise, and one that puts the health of our youngest Texans first. Together, we have created a path that expands access to life-saving vaccines while honoring the critical role of the pediatrician and the importance of the well child visits. This balanced solution strengthens the circle of care around every child in Texas, ensuring no family must choose between access and comprehensive care. Pharmacists are the most accessible healthcare professionals, and throughout the last 25 years have been vaccinating in Texas. We've demonstrated our ability to safely and effectively vaccinate millions of Texans, including children, without compromising patient safety. Expanding our authority under state law is not about replacing physicians. It's about closing gaps in care and increasing access to critical vaccines, and working as part of a broader healthcare team to protect the public health. As pharmacists, we agree with our physician colleagues on the importance of well-check visits and reinforce this with parents and patients. We are trained, qualified, and ready. This bill builds on lessons learned in the pandemic, aligns with national best practices, and ensures more Texans, especially children in rural and underserved areas, can stay up to date on life-saving vaccines. In closing, expanding pharmacist and pharmacy technician vaccination authority is a patient-centered, evidence-based step forward in Texas. It builds on proven successes during the pandemic, strengthens our immunization infrastructure across the state, and ensures timely access to critical vaccines, especially for children and families who need them the most. We have seen a significant increase
Okay,
in
thank you.
families.
Thank you for your testimony. Members, any questions? Representative Pearson.
Thank you, Chairman. Good morning. Thank you all for your testimony. I understand this is a compromise bill, but I still would like a little bit of clarity on what you're asking us to do. When we're talking about children ages 3 to 5, we don't really know what they're allergic to. So my question, I will start with Mr. Ching. You said you had an independent pharmacy?
Yeah, that's right.
Is your independent pharmacy equipped to handle a medical emergency in case one of these children goes into anaphylactic shock?
We are, yeah. So we have, we're a pharmacy, so we have access to EpiPens. We have a protocol right now that was written by a physician that gives us guidance on what to do. We're also pretty close to several hospitals, and so we already have been trained, especially when we go through our immunization training. We also go through CPR training as well. And the number one thing you always do is activate the emergency response system. I just did my training on Friday, so I'm ready. But the big thing too is we have to partner with folks too. So if there's something that we're not prepared for, we already have all of the things at our disposal. We are a pharmacy. We have access to those things that can reverse an anaphylaxis reaction. Also, we have access to medical care with the hospital, but also we are trained and we do our recertifications every 2 years for CPR. And we also have plenty of training with vaccines and also know the main side effects and a lot of the contraindications to vaccines. So as we are going through and helping people get vaccines, we're also screening for those things that would make it that this patient shouldn't get one. And those are all provided by the CDC. So I feel pretty confident in the fact that we can take care of these patients and then partner with our colleagues in the healthcare community to make sure that we take care of everybody if needed.
So is it your testimony that your pharmacy is as safe as a doctor's office?
I would say that we are safe. Physicians provide different levels of care that they are specifically trained on, but I would say getting a vaccine in a pharmacy is safe, yes.
But as safe as a doctor's office or no?
Sure, yes, as safe. Yeah.
That's your testimony?
That's correct.
Okay, thank you. For Dr. Turk, is that correct?
Yes, ma'am.
Let's see. The focus of a pharmacist education versus a physician is quite different. Would you agree?
I can testify to what my focus is, but I can't testify as to what the focus of a pharmacist's education is. I'm not a pharmacist.
I think that's a great answer, but what I'm trying to get at is pharmacists are focused on laboratory, formularies, medications, not necessarily whole system treating. So my question for you is, do pharmacists have access to the entire patient's history, as you would?
I think that they have access to the necessary information that are required to provide the service that are being asked of them.
Okay, I'll ask you again.
Sure, yeah.
Do you have access to the full patient's history?
So what we do, again, is we do an intake form, so we are able to collect that information. So like I said, for my kids, for instance, like at the physician office, they ask a lot of questions, and like I said, I'm not a physician, I'm not trained to be a physician, so I can't speak just like, a physician can't speak on the pharmacist training. However, as we go through, there are specific things that we need to collect and gather in order to provide these safe immunizations. And I do feel that in the course of us getting someone an immunization, we do collect the necessary information to be able to identify if this is something that's going to be appropriate for a patient. But that's why the collaboration between physician and pharmacist is so important, because we are sharing that information with them, and that's why we have the registry as well. So by us being able to provide this access, help get people to a medical home. Again, most kids in Texas don't have a medical home, so they don't have a physician they're going to. So for us to be that first line of defense, to be able to meet with these kids, help direct them to a pediatrician, I think we can collect the necessary information, we can do it in a safe way, and hand that off so that the pediatricians can then take the ball from there. But I do think we provide adequate care in the form of immunizations with the information provided to do that in a safe manner. And again, we partner with our physicians and our pediatricians, and together we have an entire profile. So I would say that, across medicine, the whole goal is to collaborate to create the best picture of a patient, and that's why we need to collaborate and work together like this bill is doing.
So is the pharmacist education focused on formulating a treatment plan to address a specific diagnosis?
So we are not diagnosing, and when you provide an immunization, we are not diagnosing either. So when someone comes to us for immunization, I'm not diagnosing anything, but what we're doing is we're following CDC guidelines, just as the pediatricians and the physicians are as well, but we are trained on administering vaccines. So we go through an entire course throughout the semester for immunizations, what the vaccines are, what are the protocols, how to administer, what's the technique, what are the adverse reactions? How do we handle anaphylaxis? And we're all very well trained. So, and that was my training, 10 years ago, but we've been providing, vaccines for over 26 years. And again, before any pharmacist or technician can go and administer vaccines, we have to go through this training course. And so we have to go through not just a didactic course where we learn all of this, we have to actually go through a demonstration. So we have to show correct immunization technique. We have to show that we know how to handle adverse reactions. We have to show that we know what to do when there's an anaphylactic reaction. So I feel very confident that pharmacists are trained in this way. But yes, we are trained through not only medications, but in order for us to learn medications, we also learn about all the systems as well. So I feel like a pharmacist training is very well equipped to provide immunizations.
Yes.
So in response to your question about the pharmacy access to the complete medical record of the patient that they're attending to, there are plenty of examples of immunizations being given across the state in other settings in which that's not going to occur. For example, school vaccine clinics or flu clinics or things like that. So I think that what the gentleman is stating, they have protocols, they have education, they have training, I think more than adequately addresses the concerns about the necessary skills to provide the service.
Well, my questions are coming from parents who are concerned when they take their child, 3-year-old, 5-year-old, to the doctor. There's a full patient exam, which a doctor would be able to recognize or diagnose another issue prior to administering a vaccine. So these are where the questions are coming from, so I appreciate you answering them. So I guess I'm just trying to figure out why we would want to eliminate the physician from examining the child to identify if there are any issues where the vaccine should not be administered at that time. Yes.
And I think that's the point of this bill, is that we're not eliminating, we're really partnering. And so again, the majority of kids here in Texas don't have a medical home. There's people that, again, like my pharmacy, we went across the state to Eagle Pass, Texas, to Laredo, along the border, to all these small towns, like all across Texas, providing immunizations to intellectually disabled patients. Those are patients that were wardens of the state. Those are people that have family members that don't have access to health care. And those were people that we needed to make sure that had access. And if they didn't have access to a physician or if they didn't have a medical home, again, a pharmacy, you can walk into any chain pharmacy, independent pharmacy, and ask to speak with a pharmacist, and you're speaking with a trained medical provider within seconds, And so I think we are the most accessible healthcare provider, and our job is to make sure that we can help navigate and triage people through this really confusing healthcare system. And that's why I think it's so important to partner with physicians, because if someone comes in and we're giving them a flu shot, let's tell them how important it is to go see their get their well visit from their physician. Let's tell them how important it is to make sure that they are seeing their provider regularly, because sometimes if someone's coming in and they're not already seeing a physician, but they need a vaccine for school, or they heard on the news that there's an outbreak going on in their school, or if the flu's really bad, how great of an opportunity that is for pharmacists to be able to provide that opportunity to help be a resource and education for these patients. Because again, the healthcare system is so confusing, but I feel like as a pharmacist, it's our job to help demystify that and also help attach and connect people with care.
Thank you.
You're welcome.
Members, other questions? Representative Schaffner.
Good morning. Thank you, Chair. What are, Mr. Chen, what are the duties of a pharmacy tech?
Yeah, so pharmacy technicians, they do a lot in the pharmacy. So basically, they're able to do data entry. So they type the prescriptions from the physician for us to review as a pharmacist for the final review. They will help put tablets or capsules into a bottle. They'll help label. They'll help answer our phone calls, help triage people to see if they need help with a refill. But also, more importantly, in the last 5 years with this, they've been able to administer vaccines as well. Again, they have to go through the same training that our pharmacists do as well. They have to go through an approved course by the American Pharmacist Association that goes and guidelines how to do the administration, how to do the look for different side effects. Again, all of this is still with a pharmacist being present as well. But our pharmacy technicians are so vital to the lifeblood of a pharmacy, just as a medical assistant and nurses are to a physician's practice as well.
So what would this look like practically? A mom and a child come in and then what? Say, we need a vaccine?
Yeah, sure. So I can break down. So at my pharmacy here, so we have a lot of folks that will come up. A lot of people may not know what they need, or may just say, "Hey, I heard that there might be a vaccine." We do a lot of education. So in the pharmacy, whenever there was, when the measles first were reported, a lot of older folks were saying, "Hey, I was born in the 50s or the 60s. Am I covered?" So a lot of what we do is we do education, and we help teach people, or help again break down those recommendations. And so if you wanted to get a vaccine, we would give you an intake form. We collect your information. This information, just like in a doctor's office or at a hospital, collects your name, your date of birth, what allergies you may have, any past medical history for surgical, all the things that we would need to make sure that this is appropriate. Because all vaccines have things that they warn, and some are just contraindicated, which means that if you have this, you shouldn't get this vaccine. So again, we're trying to identify the things that would preclude or stop someone from getting it. And all of that is going to be documented. It goes to our pharmacist for review. And again, in my store, we have our pharmacist providing immunizations. In a lot of other pharmacies, we have technicians that we've had technicians trained as well. But then after that, the pharmacist will review it, make sure it's appropriate. We'll get everything prepared, and then it will usually be administered to the patient in one of our vaccine rooms.
Okay, so, and you had mentioned several times that there have about adverse effects. So if there's an adverse effect, what would be an adverse effect?
Yeah, I mean, to be
For
honest, the most common side effect or adverse effect we talk about is just a sore arm and some fever, just to be honest. Some of the more serious ones that we try to at least educate people about is for certain live vaccines. There aren't really that many, but we provide like yellow fever vaccines, for instance, at my pharmacy. So again, because that's a live vaccine, which again, most vaccines are not live, but in the case of yellow fever, if you're going to Uganda or a place where there's a higher risk and things like that too, you would just make sure you look out again for a potential higher reaction of, again, fever. Sometimes people might feel like they're just kind of sick with the flu. But again, as far as it goes, the majority of the vaccines, the biggest side effect is a sore arm and potentially some swelling in the area, which we usually kind of help the patients kind of navigate if they have those issues. Again, we're so accessible, so we tell people to call us if they need. Sometimes they already are going to see their physician, or maybe their physician actually recommended they come to the pharmacy, because again, we work with a lot of physicians that maybe don't want to stock the vaccine, or sometimes we provide vaccines to physicians or pediatricians as well. So we really do partner well with physicians and try to, again, help the patient as best we can from a holistic approach.
So with the serious adverse effects, who will be liable for those effects? Would that be the pharmacist, the tech, the
Yeah, I mean,
pharmaceutical company? Who would be
yeah,
liable?
that's a good question. I don't know off the top of my head. I would have to dig through the law and everything too, but I'm not sure. So I'll get back to you on that.
Okay. Ms. Evans, do you have anything to comment on as far as the adverse effects?
Adverse effects documented in vaccine court, for instance, are up to and including death. So you have some life-changing, debilitating injuries and, fainting on site. There's a long documented history of side effects from vaccines, not all of which are included in the CDC contraindications. But to answer your last question, nobody is liable. No one.
No one is liable. Okay. So who, in your opinion, should be liable?
Depending on the circumstances, at the very minimum, the pharmaceutical company should be liable for any harm or injury, just like they're liable for other products that they create. But if there is some sort of medical error, then whoever is administering the vaccine.
Yes, sir.
We have had in this country a program that provides compensation for individuals who are injured by vaccines. It's called the Vaccine Injury Compensation Program. And it is federally, it's a federal law that went into effect several decades ago, and it takes vaccine injuries out of the tort system and provides a completely different pathway for providing compensation for the rare instances in which people are injured by vaccines.
Does that mean that federal dollars are paying these funds and supplying this money, and not the pharmaceutical companies?
So there's a 75-cent fee charged for each antigen within a vaccine. So the MMR would be $2.25. That money then goes into the general revenue fund in the federal government. So you are, as a private citizen, if you go into the vaccine court program or vaccine injury compensation program, you hire an attorney. That attorney is then fighting against Department of Health and Human Services, who is represented by the Department of Justice in an administrative court.
Great, thank you so much.
Representative Alcott.
Thank you, Mr. Chairman. So it's my understanding that this PrEP Act actually allowed pharmacists to start dispensing, it kind of loosened the rules how they could begin dispensing vaccines in response to the COVID outbreak. Is that correct? So what this bill does is correct. It actually expands the authority to include administration of all FDA and ACIP approved vaccines, not just COVID vaccines, but and for kids up 3 years and up. Is that correct?
So the bill, as presented, will do flu and COVID 3 and up, which is currently consistent with what the PrEP Act is. And currently, the Texas state law is 14 and up, and that 14 will come down to 5. So really, it's going to be maintaining the flu and COVID 3 and up like we've had with the PrEP Act. And then currently, it's 14 and up, and then that'll come down to 5 for all the other vaccines.
Okay. Well, it's obviously everyone in here understands the reason for doing that during the COVID, but now that's passed away. Why do you think this is so necessary? I mean, and you don't. It just seems to me that let's say a parent comes in and wanting to bring in their child in and have a vaccine, but they have questions about some stuff they read about or adverse reactions. Do you believe? I mean, it sounds like you're pretty educated on these issues, but do you really have confidence that a lot of pharmacists around the state are educated enough to answer those questions to a parent that has read about the potential hazardous and side effects of vaccines?
I do. Yeah, like I said, as a pharmacist, we know our training. We've all been, like I said, it's been very staple of our curriculum to go through vaccines and make sure that we understand this well. So I think as a part of going through the pharmacist curriculum in pharmacy school, I feel like pharmacists are well trained to do this. And again, vaccines access is so important. And again, I think even though the pandemic, was the reason that this kind of started, I think we can all kind of agree that providing access and making sure that we can continue to partner with other healthcare providers to, again, have access to vaccines for those that want it, I think is going to be ultimately a good thing for those folks that decide to get it. And then Amy.
If I could just add as well, if a parent comes in and they have a lot of questions about a vaccine or they read certain things, and the pharmacist goes through it with the parent, they'll also refer them to their physician. If it's questions that the pharmacist is not able to answer, or they feel like this conversation you need to also have with your physician, we will refer to the physician very regularly.
Yeah, I just have serious concerns that physicians are being. I know you're saying you're trying to have working relationships with physicians, but I think in all practicality that doesn't. It's not as easy as you say. And I'm just wondering, Dr. Turk, I'm just surprised that the TMA isn't more concerned that you're letting the pharmacists be involved in making some of these decisions, because once these kids take the vaccine, then it's really too late for the physicians to intervene. Do you have any comment on that?
So we would prefer that all of our patients come to us for all the services that are necessary in the medical home. We recognize in certain circumstances, such as annual influenza vaccination, that it's virtually and practically impossible for the entire population to get vaccinated every year for influenza. We don't have the capacity in the medical home to do that for the entire population. And so for many, many years, we have supported as many access points to influenza vaccination as possible. And so that's the rationale. We are in the midst of a measles outbreak right now. And that should be on the top of everybody's mind with respect to access to important vaccines. We want to make sure that we are striking an appropriate balance between practicality and convenience and prioritizing the medical home. We're not dogmatic about that. We have to be practical. And we have to understand that the compromises may need to be made when the needs be. we do actually collaborate quite well with pharmacies, and I regularly talk to pharmacists when I have a question about a particular medication, or if they have a question about a medication I prescribed, or there needs to be some clarification. So that relationship does exist.
So how would that practically work? So if you've got a parent inside of a Walgreens wanting to get a vaccination but has some questions and the pharmacist doesn't know how to answer them, how easy would it be to actually call up a physician and get that answer when the physicians are in the middle of seeing patients?
So I think it's going to vary from situation to situation, but as the other witness testified, if there's a question that is more than a straightforward what happens with this particular vaccine, what adverse reactions can we expect, if there's a deeper question, then I think it's reasonable for the pharmacy to say, you know what, I think that you have more questions than what we can answer right here. Why don't you follow up with the physician about this? And they'll come to see us and we'll talk about it. And if it's appropriate to give the vaccination at that time, almost certainly we'll provide it in the medical home.
Okay, thank you.
Okay. Representative Pearson.
Thank you, Chairman. Doctor, you'd mentioned the vaccine program for injuries, the compensation program. What is someone to do if a pharmaceutical company is immune from the program, which we saw with COVID? These pharmaceutical companies were giving immunity. So what is a family to do if these pharmaceutical companies are given immunity? I'm trying to figure out what recourse these parents would have.
I guess I don't understand the question. What are they to do in what circumstance?
Yeah, we're talking about liability. You mentioned the vaccine injury program where you could somehow seek liability. But what if there's immunity there? That means that someone can't seek liability and these families are just stuck with all the damage that has been caused by some of these vaccines.
What damage are you speaking of?
Well, I mean, look at myocarditis, which is one of the things that came out of COVID. And there is a statute of limitations to make these claims as well. So I was just curious, back to the liability question. I mean, this discussion reminded me that COVID, for example, was one of the vaccines that was the pharmaceutical companies were given immunity.
Sure. If we could just, I'll be happy to walk through that particular situation with you since you brought up myocarditis. So myocarditis is a recognized potential complication arising from some COVID vaccines in certain populations, but it is a very rare event. And the risk of myocarditis actually is much, much higher with COVID-19 disease than it is with the vaccine. However, if somebody gets myocarditis in the context of a COVID-19 vaccination, which we're not really focused on COVID-19 here, but if they happen to have that condition, it typically arises within the first few days following the event, following the immunization. And if they have a complication such as that and they wish to seek compensation, then they access the Vaccine Injury Compensation Program, and there are well-described processes for doing that. The program is intended to indemnify pharmaceutical companies from liability so they can actually produce vaccines without fear of multi-million-dollar judgments against them. If that was there, then they would not come out with vaccines to protect the population. So what are they to do? Well, they have a program in which they can be compensated for injuries that if they have injuries from vaccines, and that program makes them whole financially if that's what they are seeking.
So you're saying that the government did not waive liability for those specific vaccines. And I use the vaccine because that's really the elephant in the room when it comes to vaccines, particularly after the pandemic. So
I'm sorry, what is the elephant?
the COVID vaccine, you said we're not focused on it, but we really are, because that is one of the vaccines that has caused a lot of confusion all across the country. And parents are concerned that we're going to skip the doctor now when administering these vaccines with a bill like this. So I'm just trying to find ways to reassure families, since this is a agreed upon bill, that these issues aren't going to be a problem, particularly when the pharmaceutical companies were exempt from liability. So again, it's back to the liability. I think Representative Schaffner asked the question, so it would be helpful for families to know if they're going to have recourse. With tort reform, it's really hard to get a lawyer if your child has been injured. So we're trying to figure out how to give families comfort in moving forward with this.
I think that the foundation of your question is that the families don't have recourse, and they do have recourse if they've sustained injury from vaccines, whether it's an individual or a child. And that recourse is through the Vaccine Injury Compensation Program.
Okay. Ms. Evans, do you have anything to add to that?
Well, as far as and there are caps there, so making somebody whole when their child has died, that's pretty difficult when there is an economic cap. Second of all, in order to find an attorney that will take a case to the Vaccine Injury Compensation Program, there are very few attorneys nationwide who are trained in that program and are willing to take on those cases. So I think he's oversimplifying it. I think there's also a concern that, well, that came up just now, that this pharmacist who is well-trained in immunization practices did not know about this vaccine injury compensation program, so is not able to communicate that to patients. I haven't heard anybody talk about the vaccine adverse events reporting system, whether or not we should be requiring anybody who vaccinates a child to be trained on that, to be trained on reporting, to know what it is. And in Texas law, there are a variety of people who are authorized to take a child to get an immunization, not necessarily just their parent or guardian. So whether or not that person is going to know that child's family history when they're filling out a simple intake form, there's just a wealth of concerns that we have about the safe access and follow-up and the training necessary to vaccinate a child safely.
Thank you.
Thank you.
Representative Johnson.
I didn't want to get too far off track on this, but in the beginning of COVID-19, New York experienced more death because of the concentration of population and the lack of vaccination, and Texas was relatively low for either one of the pharmacists that can answer that. Is that right? You are aware that that's right?
Yes.
And then even after vaccinations came out and we had vaccinations, that is when Texas saw its height of death from COVID-19 because of vaccine hesitancy. And Texas significantly surpassed the rest of the nation in preventable deaths. Is that right?
That is my understanding, yes.
And the concern would be vaccine misinformation, just like we're seeing in MMR right now, where we've had 2 children die because of a refusal to have their freedom-loving parents provide them vaccination,
Incorrect.
as opposed to when we had almost made measles no longer an issue or death rate for children.
I think that there is a tendency to overestimate and overemphasize risk from acts of commission in giving a vaccine versus acts of omission, which is not giving a vaccine and accepting the risk that is already there, which is from the diseases that we're trying to protect people from. I've been a pediatrician for over 25 years, and I've given tens of thousands of vaccines over the course of my career. I have never had a serious adverse event occur in any of my patients. It does happen, but these are infinitesimally small frequencies. And we always are much more worried about, what if I do something that's going to hurt somebody? Well, the fact of the matter is, and we're seeing this with measles, the successful leveraging of people's concerns about risk from vaccines has resulted in a withering of our vaccine coverage rates, which is why we're now seeing the outbreaks that we're seeing right now.
And again, we're not a nation that mandates vaccinations. It's completely by choice, but that choice has to be with some scientific backing and legitimate public dialogue around public health and risk. So I appreciate you all being here on all sides to have the dialogue. It's an important dialogue.
And may I address something? So the children who died, they are from a very religious community. It's not freedom-loving parents. I think that and I think
They're
the
Mennonites,
Department
right?
of, correct.
And the
Department
issue
of
is-
State Health Services Executive Commissioner came here in our first Public Health Committee hearing, and she talked about how they are in that community now. There have been a lot of parents there that have accepted the public health agencies coming into their community. That's just a deeply held religious belief. It's not. I think it's a misnomer to say that they're just these freedom-loving parents that want their choice. They're deeply religious.
Are all of them deeply religious?
in the Mennonite community?
I'm not asking about the Mennonites. The problem is what we've seen over the last decade is that we're seeing counties get to that tipping point of almost 5% unvaccinated. And what that means is there is no freedom or choice for other parents who have immunocompromised children who can no longer go to the grocery store or put them in school because other people are choosing something that at the moment seems to be a politically motivated debate. So I'm all for religious freedom, but I think it's hard for us to suggest that the increase in what we've seen around this is not based on religion, it's based on politics, and that's what worries me. This is a public health discussion.
And that's a valid perspective to have. I was speaking specifically to the cases that you were referring to.
And those children died.
Correct.
Thank you.
Representative Schaffner.
Thank you. Dr. Turk, are you, as a pediatrician, for the infinitesimal amount of adverse effects that you've seen, are you required to report those adverse effects?
If there is a serious adverse event arising from of an immunization that I provided, then yes, I make a report to the Vaccine Adverse Events Reporting System.
And what is defined as serious?
Anything.
Is that your judgment, or is there some sort of protocol?
Well, there are going to be adverse effects that are common and which are not reportable, such as injection site swelling, a rash, soreness at the injection site, low-grade fever, anything that is. There are standard definitions of serious adverse events, and if it is a serious adverse event as opposed to a common expected side effect from a vaccine that is self-limiting and not significant, then it's something that we do make a report on. Yes.
Thank you.
Okay. All right, thank you for your testimony. Is there anyone else who wishes to testify on, for, or against House Bill 3540? If not, Chair recognizes Representative Harless to close. While he's coming up, I want to remind everyone we do have an overflow room, room E2036. And I know the sergeants are going to try to keep the doors clear. So if you can assist them in that, it would be greatly appreciated. Chair recognizes Representative Harless.
Thank you, Mr. Chairman and members. This bill is only about access. It doesn't mandate anything. In a perfect world, all of our children would have a pediatrician or a family doctor to go to, but they don't. And with that, I want to thank TMA, the Pediatric Association, and the pharmacies for coming together and getting agreed upon language, and I close.
Okay, I think we have a question. Representative Jones.
Yes, ma'am.
I actually don't have a question, I have a comment.
Yes, ma'am.
I'd like to thank you with all the discussion in this committee about doctors and pharmacists, the fact that you were able to get TMA and the pharmacists on the same page. Hallelujah, thank you, Jesus.
And the pediatricians.
I'm glad I got some levity out of this. So you are doing God's work.
Thank you. I appreciate that.
Thank you. Okay, Chair withdraws committee substitute. If there's no objection, House Bill 3540 will be left pending. Is there objection? Chair hears none. House Bill 3540 is left pending. Chair lays out House Bill 4420. Chair recognizes Representative Rose to explain the bill. Chair lays out a complete committee substitute for House Bill 4420.
Good morning. Which one did you say?
4420.
Okay, 44th one. All right. Thank you, Mr. Chairman. Good morning, members. All right, thank you for the opportunity to lay out the committee substitute for 4420. The committee substitute reflects technical changes made in collaboration with HHSC to ensure the data capture fulfills the study purpose and aligns terminologically and reporting metrics to the necessary standards. Members, Texas has made significant strides in investing in mental health care infrastructure, but our system is still strained. Use of inpatient beds at mental health facilities increased 12% between 2023 and 2024. Competency restoration waitlist for patients deemed incompetent to stand trial spans from months to over a year, frequently averaging over 200 days. In 2024, over 1,700 Texans were waiting on beds. According to a state audit, 54 of those people on the wait list between 2018 and 2023 died. To combat this crisis, this bill directs HHSC to evaluate current bed capacity and project future needs across the entire system. The study would capture critical data on both state and private facilities to provide a complete picture of available resources. It also calls for the evaluation of the current number of beds in competency restoration, civil commitment, juvenile and adult beds, and intellectual and developmental disability status. So this study would also estimate all the patients who would require long-term and workforce capacity needs. Member HHSC will also submit a report to the legislature with the results of the study and also make legislative recommendations. So remember, this bill will provide essential data to help us make informed policy decisions on mental health care capacity needs. Thank you, Mr. Chairman, and I reserve the right to close.
Okay, thank you. Members, any questions of Representative Rose? Okay. We will reserve your opportunity to close. Chair calls Stacy Wilson and Lizette Galvin.
I'm gonna stay right here.
Okay. Stacy Wilson?
Yes, sir.
Okay. Show Stacy Wilson testifying as president of Children's Hospital Association of Texas for House Bill 4420. Is that correct?
Yes, sir.
Thank you. You may proceed.
Thank you, Chair Van Dever.
Excuse me,
Vice
and you're
Chair-
for House Bill 4420?
Yes, sir.
Thank you.
Thanks for clarifying that. Good morning, Chair Van Dever, Vice Chair Campos, members of the committee. My name is Stacy Wilson. I am the president of the Children's Hospital Association of Texas. We represent 11 not-for-profit freestanding children's hospitals across the state. And on their behalf, I am testifying for House Bill 4420. When the horrible events in Uvalde happened, we got a call from state leaderships asking us 3 questions. They were, what resources do we need for kids with mental health conditions? Second question was, what resources do we need? And then the third question was, what cost are we gonna incur to try to fill that gap? And unfortunately, the answer to all 3 of those questions was, we don't know. The state didn't collect that data. So in response, you all in the legislature required 2 things to happen. The first was a strategic plan for children's mental health that HHSC has created. The second was a study by Texas A&M University Health that is looking at the resources available to children with mental health conditions. The first thing that they discovered was that about half of all pediatric inpatient utilization is for a psychiatric condition, which was really shocking. We didn't expect it to be that high. Secondly, they figured out we don't know what resources are available for children. We don't collect that data in terms of how many beds are available, what other resources are available, and then how beds are segregated by children, because in terms of age. You don't want a 4-year-old in with a 17-year-old, for example. So one of the great things that House Bill 4420 does is it requires hospitals to report that data on a form they already fill out. It's just one more piece of data that will help Texas A&M University figure out what resources are needed for kids with serious mental health conditions. It also will help inform the next piece of the strategic plan as we move that forward. And so we're very grateful to the Representative Rose for bringing this, and I'm happy to answer any questions.
Okay, thank you. Chair recognizes Lizette Galvin, testifying on behalf of public policy. You are the public policy director testifying on behalf of NAMI, Texas, N-A-M-I, Texas, and you are for House Bill 4420, is that correct?
That's correct.
You may proceed.
Good morning, Chair Van Dever and members of the committee. My name is Lisette Galvan, and I serve as the Public Policy Director for NAMI Texas, the Texas affiliate of the National Alliance on Mental Illness. On behalf of our organization, thank you for your continued commitment to improving the mental health care system in Texas, and I'm here to testify in strong support of HB 4420. Every day we hear from families across the state who are doing everything right to get their loved one help during a mental health crisis, only to find that there are no psychiatric beds available. Emergency rooms are backed up, community hospitals are closing their doors, and our state hospitals can't operate at full capacity due to staffing shortages. The system is failing people when they need it most. Nowhere is there more apparent than the growing forensic waitlist where individuals found incompetent to stand trial are waiting months, sometimes over a year in county jails for a state hospital bed. These delays are harmful and costly. At the same time, we're advancing policies that propose new entry points into care, including EMS transport and jail diversion efforts, but we have not answered the core question: where are people supposed to actually go? HB 4420 addresses the gap. This bill directs HHSC to conduct a comprehensive statewide assessment of Texas's inpatient psychiatric bed capacity, including a projection of future beds and a breakdown by region and population type. It also looks at workforce availability and long-term residential options where major barriers are to activating existing capacity. This kind of data is essential. Without it, we're making policies and allocating resources without understanding where the true gaps are. HB 4420 ensures a more transparent, data-informed picture of Texas's behavioral health system and supports data-informed decision-making around future investments and policy design. Thank you, and we urge you to
Thank
support
you.
this bill.
And Representative Rose corrected me, it is not NAMI, it is NAMI. She obviously is not from East Texas. Members, any questions for this? This is okay. Thank you for your testimony.
Thank you.
Is there anyone else who wishes to testify on, for, or against House Bill 3540? Okay, were you registered?
I've registered but not to testify, but I believe I do want to testify.
Okay, hang on.
My name is Guy Herman. I signed up for this bill in favor of it.
Okay, we show you Guy Herman, a judge, testifying on behalf of statutory probate judges of Texas and yourself, and you want to testify for House Bill 4420, is that correct?
Absolutely.
Okay, do we have your permission to change your registration to for?
certainly do, sir.
Okay, thank you, you may proceed.
Chairman Van Dever, Co-Chair Campos, I've been studying this for 40 years. We are in a crisis right now. We are 1,800 beds short today. The state demographer says we're going to grow at 12% a year, and in 15 years or less, we will be bigger than California. If you just take 1.12 and just multiply it out and keep adding to it, we will be at 2,500 bed shortage within 3 years, I believe. And if you just keep moving it out there, we are going to be, by the time we're bigger than California, needing 10,000 beds. That means serious consideration by this legislature to build more and more beds. We are backed up right now. We can't, people sit in the jail. I'm a big fan of NAMI. However, they've done some policy ideas that I disagree with because they want to put mentally ill people who don't admit they're mentally ill and who are not dangerous into mental hospitals. I disagree with that. We need to have more outpatient services. We need to have more court monitoring services that we do here in Travis County and in other counties. Right now, the federal government is talking about getting rid of a lot of federal monies that will be going back to the states. I allegedly was told that this is happening in Arizona, that they've got this special way of dealing with people. I go call up a person over there, the Superior Court judge, who is equivalent to what I do. I go around the state lecturing about mental health. That person says, I don't even know what you're talking about when you use this term. in using that term, it's anorexia. You go over there in Arizona, they say, we are worried, we don't have the beds over here. The federal government's talking about cutting it back down. We're going to have to face this crisis.
Judge, thank you for your testimony. Is there any questions? Okay. Is there anyone else who wishes to testify on, for, or against House Bill 3540? Okay. If not, Chair recognizes, sorry, let me back up. Got to. Is there anyone else who wishes to testify on, for, or against House Bill 4420? If not, Chair recognizes Representative Rose to close.
Thank you, Mr. Chairman, for the opportunity to lay this bill out. You know, most of you know that my background has been in correctional mental health. And I spent, majority of my career in correctional mental health and was a liaison between the courts and the psychiatric department in Dallas County prior to running for office. And this has been an issue since, I began there in 2000. And here it is 25 years later. The state has kicked the can down the road when it comes to state hospital bed capacity. And I feel like this is the first step, to provide the foundation that we need to try to make sure that we have strategic investments as it relates to mental health capacity. And so with that, I close.
Okay, I believe we have a question from Vice Chair Campos.
It's just a comment. I want to thank you so much for this bill. I do a lot of work in the interim with Child Protective Services, and so I've seen so many kids that really need psychiatric help, but yet they're staying in motels, and that's not okay. So just wanted to, thank you for your work on this. It's a great bill.
Thank you. I appreciate that.
Okay, members. All right, Chair withdraws committee substitute. If there's no objection, House Bill 4420 will be left pending. Is there objection? Chair hears none. House Bill 4420 is left pending. Chair lays out House Bill 4421. Chair recognizes Representative Rose to explain the bill.
Again, thank you, Mr. Chairman, members, for the opportunity to lay out another bill, which is HB 4421. Members, I do have a committee substitute that more accurately
Okay,
aligns the definition.
Hang on, I don't think we have the committee substitute. So
You don't have the,
you can just lay out the bill and,
I understand that. I did not know that you did not have the committee substitute. Ally? Where's my legislator? Well, all right. Well, this is not a committee substitute, so, I'm ready, Mr. Chairman. Thank
Okay.
you again, members. I apologize for that. But, Developing Texas Peer Recovery Organizations, or PROs, are an innovative approach to recovery that play a vital role in substance use disorder and mental health recovery. These entities leverage the lived experience of people in recovery to deliver evidence-based peer support, build community, and also connect individuals with crucial resources. Because peer recovery organizations lack a clear statutory definition, it can be difficult for the PROs to access the grants and resources intended for their use. So HB 4421 addresses this challenge by, one, establishing a comprehensive definition of peer recovery organization that clarifies their structure and composition. It also directs the relevant agencies to identify funding, training, and technical assistance for peer recovery organizations, and it also mandates biennial agency reports to document efforts of support recovery organizations. So by providing essential service to individuals on their recovery journey, PROs complement clinical services and improve recovery outcomes. So, members, this bill basically strengthens our recovery ecosystem by supporting transformative work of peer recovery organizations. So, thank you, Mr. Chairman and members, and I reserve the right to close.
okay. Members, any questions for Representative Jones?
So we should expect a committee sub, right?
I'm not gonna speak on that because
Okay.
I don't
Okay.
know. Yeah, this is,
Okay. All right, I believe we have a couple of witnesses. We will call, Chair calls Elizabeth Henry and Joe Powell. Okay, I show Elizabeth Henry, Director of Policy. You're testifying on behalf of Recovery People, Texas Coalition for Healthy Minds, and yourself, and you're for House Bill 4421. Is that correct?
Correct.
Thank you. Proceed.
Chair Van Dever and members, thank you so much for the opportunity to speak with you all today. My name is Elizabeth Henry, and I'm a woman in long-term recovery. I serve as the Director of Policy for Recovery People and the co-chair for the Texas Coalition for Healthy Minds. Today, I'm representing both organizations in strong support of House Bill 4421. Peer recovery organizations are nonprofits that are locally governed and led by individuals with lived experience in mental health or substance use recovery. They provide non-clinical services such as peer support and resource navigation. PROs have been shown to strengthen recovery outcomes, lower relapse rates, and reduce reliance on costly taxpayer-funded systems like emergency health care, CPS, and the criminal justice system. Currently, Texas invests in public dollars for recovery-oriented initiatives, but without a clear definition, many of these funds have gone to traditional treatment providers rather than true peer-led organizations. Defining PROs ensures that funds are directed to organizations that provide these cost-effective, community-based non-clinical supports, thus freeing up clinical systems to focus where they are needed the most. 4421 strengthens accountability and transparency by requiring agencies like HHSC, DFPS, and TDCJ to identify available resources, training, and technical assistance. And it also mandates a biennial reporting to the legislature so that our policymakers can make informed strategic funding decisions. By extending recovery support into everyday life, PROs build workforce capacity by training certified peer specialists, create job pathways, and strengthen community resilience, all at a fraction of the cost of without extending government reach. We are very grateful to Representative Rose for her continued support for the wellness and recovery of all Texans, and I respectfully urge you to support House Bill 4421 and vote it favorably out of committee. Thank you.
Thank you. Chair recognizes Joe Powell, testifying on behalf of the Association for Persons Affected by Addictions and yourself, and you are for House Bill 4421. Is that correct?
Yes, sir.
Thank you. Proceed.
Okay. My name is Joe Powell, and I am a young person in long-term recovery, and what that means is that I haven't had alcohol, drink, or any other mood-altering substances in 35 years. It's only because of recovery, though, that I am the president and CEO of APA, the Association of Persons Affected by Addiction in Dallas, Texas, now for 26 years. Also, as a taxpayer and an advocate for, of course, any kind of fiscal responsibility and public policy. I originally support, and thank you very much for having me here, to also for the House Bill 4121 for peer recovery organizations. Only 6% of Texas residents right now who need mental health and substance abuse treatment get it. There are multiple causes for this lack of treatment access. North Texas faces a shortage in mental health and substance use professionals, making it harder to access timely, appropriate support and care. Additionally, financial barriers and gaps in insurance also coverage is limited in treatment, and especially with treatment options. Overdose-related fatalities in Dallas County have increased by a staggering 81% between 2019 and 2023. The overprescription and misuse of opiates are taking a toll, resulting in death throughout the state of Texas. As the original pioneer in Texas, APA, my organization, the Association of Persons Affected by Addiction, introduced and initiated peer support services by increasing the workforce, maintaining a staff that serve an average of over 1,000 unduplicated individuals and family members and over 20,000 duplicated support services every year. Peers, APA, is a national accredited organization. It's called CAPERS, National Council on Accreditation for Peer Recovery Support Services now, and we hold an exemplary status. In CAPERS, we have 30 standards to live by. to ensure the fidelity and
Powell.
safety within.
Thank you. Thank you for your testimony. I'm sorry to cut you off.
Okay.
And by the way, congratulations on your many years of sobriety. I know that. Members, any questions of these? Representative Schaffner.
Mr. Powell, would you like to continue?
Yes. So as a original pioneer, again, and the organization does have 30 standards that we have to live to ensure the fidelity and safety of peer recovery organization. For 26 years, again, APA has been at the forefront in providing life-saving and life-changing peer-to-peer support and supports that personalize, evidence-based, and aim at achieving long-term recovery with a community of care. So we offer specialized, peer-driven, peer-led, and managed recovery management programs, including over 160 support groups per month for every person and families, and also virtual recovery, and of course with family and recovery education. Our mission, APA's mission, is to educate all segments of the community about addiction and mental health, wellness, and recovery, and provide recovery support services. Some of our partner organizations, we've partnered, of course, throughout the state, including with the Texas, the governor, even with the Texas Workforce Commission. I introduced peer support for the workforce to increase the workforce and for them to be knowledgeable about peer support services. Also, with the district attorney, Health and Human Services, our county commissioners, Opiate Abatement Council, Parkland Hospital, churches, and of course, we have a large peer organization that what we call peer organizations for the government, as far as, what is it, POGA is what we call it, which is several peer organizations, over 30 peer organizations in the state of Texas. And to end it, let me see. As the first accredited peer organization, APA is living proof. We are living proof that peer recovery organizations are a solution for health, wellness, and recovery. We have introduced peer support and peer organizations to the state in many different ways, and of course with the justice system, and definitely throughout the systems of care. Hospital diversion, jail diversion, we do that very well with our local behavioral health authority, and this bill here strengthens our accountability and maximizes peer organizations with the impact, of course, and with the state dollars by clearly defining what is a peer organization and also directing existing state agencies to report on available resources and funding. It ensures that public funds are directed to locally governed nonprofit organizations with a proven record to mobilize and extend community supports to deliver cost-effective mental health and substance use services. And of course, peer recovery organizations reduce in reliance, and it's very cost-effective, but also in emergency rooms, incarceration, people who are incarcerated, state-funded treatment, and helping individuals sustain recovery through peer recovery organizations. I think my mouth is getting dry, so we're definitely, we want to, of course, prevent. Peer organizations also prevent, when you're talking about ACEs, adverse childhood experience, how do we prevent all of that? How do we prevent incarceration? How do we prevent more in families, right? So peer organizations build the recovery capital that promotes sufficiency and relieve pressure on the justice system, the healthcare system. So we definitely, House Bill 4421 promotes personal responsibility and local leadership, and it limits the government by investing in recovery solutions of work. Thank you.
Thank you. Members, any other questions? Representative Schaffner.
This is for anyone, who's most likely going to seek out the peer organizations, families or the individual that is suffering from addiction?
Both. Yeah, both. We have just as many families because of people in the family, right? And usually it seems like that most people do have someone that have a mental health challenge or an addiction, and they don't know where to get help. To have a peer organization, and we have a recovery center, so you can have a center there, right, where all of the people come in and out. Also, of course, with the hospitals and emergency rooms, we also have different settings. But to have that in a community where people can walk in, okay, and to get service, then that's families and individuals.
So this would just be a one-stop shopping, so to speak? Is that what this bill does?
Well, it's more, yeah, one-stop shop can be the one center, Recovery Community Center, but it offers so much. We have a menu of services that we do, including recovery at the movies, including jamming and recovery, right? So including family potluck, right? And so we actually do a lot of things when it comes to, when you say one stop, you know, what are you stopping for, of course? But again, definitely the whole goal is health, wellness, and recovery, though, not treatment. So again, so when people get out of treatment, when they get out of jail, when they come out of when they're having problems with the family or the community, this is a place where you can go and get that peer support, where people with lived experience just like that person.
And so how would families find out about this?
Many different ways. Again, like I said, we are all over when it comes to it. That's the goal, is to how do we spread health, wellness, and recovery? How do we be louder about it? Yeah. So we're not on television like we would love to be more, but definitely, yeah, through our email and our website, right, apparecovery.org, right? Of course, we do a lot of community outreach. So that means that every week we do outreach, right? And we go to different communities and in the courts and churches, wherever people are, we know that addiction and mental health challenges are there, but recovery is not loud enough there in those places, right? So wherever people are, we want to be there.
So sobriety is different than recovery.
Totally.
How is that?
Yeah.
You want to speak on?
I'd like to, just to kind of add on to what Joe was saying, you know, recovery community centers and our mental health community centers, there's, as far as substance use recovery, because that's the perspective that I come from, there's one thing to stop using, but learning how to live life without drugs and alcohol is a whole nother ballgame. And that is something very uniquely our RCOs, our peer substance use centers are for. I mean, like, it's even simple things like navigating the bus system can be really overwhelming, especially to somebody who's new in recovery. I've lived in Austin for almost 20 years now, and I still have an issue with the bus system, but we'll take that up next session. You know, I also wanted to mention that a lot of our treatment centers, especially our state-funded safety net providers, our local mental health authorities, they are really in tune with what's in our community, and that's another way that people can find resources, right? Because most people that haven't ever entered into recovery or gone to treatment for mental health or substance use are not going to know what resources are out there. And so our peer organizations, being so community-based, work with so many different elements that are out in the community, everything from drug courts to our jails to our local mental health authorities. So they do a really good job of making sure that people know where they are.
And one more thing, just to add to your question as far as sobriety and recovery, right? Because again, someone just being sober doesn't mean that they change all their behaviors, right? Whereas recovery is you living by principles and practices, and we honor all paths of recovery. There's many roads of recovery. But recovery, you need to know, again, what is that path? What are the principles, right, that you're living by, whether it's Christian or 12-step or Dharma, you know, Unplugged. There's over 100 paths of recovery. So as a recovery coach or recovery specialist that is trained, you'll learn to walk with that person and be that traveling companion is what we call it, with their family, right? To let them know what is recovery. We're walking together, right? So it's totally different from sobriety, from just getting sober, right? And I'm still doing some of the same behaviors. I'm just not drinking or drugging, yeah.
Right, and repairing the family relationships that
Yes.
a lot of the addictions can injure and hurt, damage. Thank you so much.
Thank you.
Okay, members, any other questions? All right, thank you for your testimony. Is there anyone else who wishes to testify on, for, or against House Bill 4421? Okay, if not, Chair recognizes Representative Rose to close.
Thank you, Mr. Chairman. I just want to acknowledge the fact that Mr. Powell, in his 35 years of recovery, I think in his work, he's done a lot of great work in the Dallas community, and I'm glad that he's here today to testify on this bill. Thousands of people that he's helped through recovery, so I just wanted to acknowledge and appreciate his work, and just thank both of my witnesses for being here today. And so I'm not going to take up too much more of your time, but just say that this bill provides a statutory framework for PROs that they need to thrive and ensure agency support. And so I just ask that you all vote favorably. I think I'm dehydrated too, Mr. Powell. Y'all need some water up here for the witnesses. But I just ask that you voted favorably. in support of House Bill 4421. Thank you.
Okay, thank you. Let me see. If there's no objection, House Bill 4421 will be left pending. Is there objection? Chair hears none. House Bill 4421 is left pending.
Thank you.
Thank you. Chair lays out House Bill 1656. Chair lays out a complete committee substitute and recognizes Representative Howard to explain the bill.
Thank you, Mr. Chair and members, for the opportunity to lay out House Bill 1656. This is one of those things that, it's a bill that came to me that seemed very simple at first, and as oftentimes happens, becomes quickly very complicated. I'm going to lay it out here the best I can, and there are some witnesses that can hopefully provide more expertise to any questions that you might have. Like most of my legislative agenda, this began with nurses, the Nurses Association, but not in the typical way that I bring bills to you. Scott Rubin, the president of the Texas Police Chiefs Association, approached me at the Texas Nurses Association's Workplace Violence Summit with an idea to reduce hospitalizations and incarceration of Texans experiencing a severe mental health crisis, while also expanding capacity of law enforcement. Since then, my office has worked tirelessly with the Police Chiefs Association, the Austin EMS Association, the medical directors, paramedics, and many more stakeholders to craft the committee substitute for House Bill 1656. According to NAMI, 1 in 5 adults in the U.S. experiences mental illness each year, and nearly 3.4 million Texans have a mental health condition. Despite significant need, Methodist Healthcare Ministry reports that more than 80% of Texas counties are designated as mental health professional shortage areas, with the majority being in our rural counties. When people do not have access to mental health counseling and treatment, their conditions can escalate into a mental health crisis, including psychotic episodes, suicidal ideation, substance-induced crises, or even catatonia. Currently, if a Texan is experiencing a mental health crisis and presents a substantial risk of harm to themselves or others, only a police officer may initiate an emergency detention order, or an EDO, to detain the individual and transport them to a mental health facility. As a result, law enforcement officers are often the primary mental health responders in many of our communities, which creates its own set of challenges. Law enforcement officers are not medical professionals and have limited training in mental health and crisis intervention. This can sometimes lead to contentious encounters between police and individuals in crisis that can escalate into unnecessary criminalization, arrests, and further trauma. Additionally, the requirement for police to transport detained individuals to a mental health facility can divert public safety resources away from the community, again, especially in our rural areas. A 2023 report by the Texas Judicial Commission on Mental Health found that some officers have to drive over 300 miles round trip to transport an individual to a facility. For a community that has only a handful of officers on duty at any given time within their community, this presents a significant drain on law enforcement resources. Furthermore, despite efforts to increase mental health training for peace officers, police are not formally trained to recognize, assess, and treat mental health conditions, relying instead on the experiences that they learn on the job. This is why law enforcement advocates assert that first responders, such as paramedics, are more qualified to assist individuals suffering a mental health crisis. House Bill 1656 aims to help communities shift to a more health-centered approach when responding to a mental health emergency by expanding emergency detention authority to EMS medical directors and proper training, and allowing them to delegate this authority to trained paramedics under their employment. Under this bill, an EMS medical director or trained paramedic would be able to initiate an emergency detention order for an individual experiencing a mental health crisis who presents a substantial risk of harm to themselves. A paramedic who initiates an EDO will have to transport detained individuals to the nearest suitable mental health facility for a preliminary examination, and will have to fill out a form detailing their reason for initiating an EDO. House Bill 1656 is not a statewide mandate. It does not require a community to adopt this model. Instead, the local EMS medical director will decide whether this model is the right fit for their community and the paramedics that they employ. Under this bill, medical directors and paramedics would first have to complete a training developed by HHSC. This training would be designed in consultation with local mental health authorities and EMS medical directors chosen by the executive commissioner. This course would provide information on best practices for crisis intervention services, information regarding self-defense when detaining and transporting an individual, documentation requirements for a person who detains and transports an individual, and best practices for communicating with witnesses of a mental health crisis. Additionally, medical directors who choose to authorize paramedics to conduct EDOs will take an administrative course of this new authority. I'd now like to turn your attention to some of the key provisions in the committee substitute, and I'm going to try to do this as quickly as I can. I'm sorry to lay out so much, but this is a very complex situation. This legislation has been highly negotiated, and many of these changes came directly from law enforcement, EMS providers, and mental health advocates. In the committee substitute, we expanded emergency detention authority to medical directors. We made this change because all EMS personnel operate off of their employing director's medical license. So this change was necessary for the bill to work. We also included liability protections for paramedics and medical directors who act in good faith and without malice, and expanded the protections to medical directors and paramedics in communities that choose not to expand the authority. The committee sub also increases coordination between EMS providers and law enforcement entities by requiring a medical director who chooses to expand emergency detention authority to notify all law enforcement entities within their service territory. The intent of this bill has never been to completely remove law enforcement from the equation. This bill actually came from law enforcement. Our intent has always been to create a model in which they can, when appropriate, play a supportive role in mental health crises. This is why we require medical directors to notify and work with their local law enforcement department. The sub requires law enforcement agencies to update their emergency detention policies when their local medical director's decision is made to implement this program. Lastly, the committee sub clarifies that if a paramedic responds to a call and determines there is a risk of harm to themselves or others, law enforcement shall respond to initiate the EDO and transport the individual. The truth of the matter is that no mental health emergency plays out the same. And while we believe that paramedics have the necessary skills to successfully handle most mental health calls, some situations can escalate to a point where law enforcement is absolutely needed. This bill presents a bold new strategy to help reform how Texas communities respond to mental health emergencies. The intent of this bill is not to increase the number of emergency detentions, but rather to shift mental health calls into the realm of public health by prioritizing treatment and compassionate medical care in the community with medical transport as a last resort. We're aware that this approach might not work for every community, and we're not trying to interfere with communities that have implemented successful diversion programs. However, if there's one takeaway that I can bring from the countless stakeholder meetings that my office has held, is that the current police-reliant model is not working. Before closing, I'd like to reiterate that this bill has truly been a collaborative effort among stakeholders, and I'm proud of the work that's been put into this bill to find common ground on an incredibly challenging issue, and I am extremely grateful to my staff, especially Henry Davis, who worked tirelessly with the stakeholders to try to craft something here that we could get common agreement on. There are several witnesses here that can answer your questions. I will try to answer some that you might have now and reserve the right to close.
Okay, I think Representative Frank has a question.
Yeah, thank you, Representative Howard. Really appreciate this bill. The way I look at it, excuse me, we either give mental health training to law enforcement or we give law enforcement powers to mental health professionals, it seems. That's kind of where we are. Right now, we're saying we're not giving enough mental health training to the law enforcement, but it seems like what your bill does is give law enforcement powers to mental health professionals. Is that the way, am I oversimplifying? It's not supposed to be a catch.
No. I would not say we're giving law enforcement powers, although law enforcement is currently the only one that has authority to do this. The fact is that we know that mental health crises can be escalated oftentimes when there is a law enforcement presence.
Okay.
And so de-escalation is part of what we're looking at here, having people who are trained in mental health crises, but also knowing that there are times when there is public safety involved and we need the police officers to be present. So it's really way you said it, yes, I could accept that, but at the same time.
I really wasn't trying to apologize if
No, and I don't think you were. I appreciate that. I think it's just as simple as saying, let's have mental health professionals be the ones that do the EDOs if possible, because they have the background and training in this, but have the police and law enforcement involved when there is a safety issue where they should be involved. And hopefully doing it this way would decrease the hospitalizations and incarcerations, and also allow police officers to be available in their community to take care of public safety issues.
Okay, so just a couple other quick questions. How long, so we talk policing authorities, how long can a mental health professional under this bill detain somebody against their will? Like that's the detention, right? Like
Yes, and there are limitations, and I'm going to have the experts give you better answers than I can. I know that there's a 42-hour initial period of time to once they arrive at the mental health facility to be examined by a physician within the first 12 hours, I believe, and then there can be an extension up to 72 hours. Again, this is not my expertise. I'd rather the people who do this answer
I'll
that
ask them.
specifically.
So I think I will, just for the people coming up, I guess they can answer it without being asked. How long can under the bill, how long can they be detained? What rights, are they read their rights, that kind of stuff? Because I do feel like we are giving, the ability to detain somebody is literally a police action, period. Like, it is a police action, and so if we're giving that to somebody, we need to make sure the other side of it. So 2 quick questions, if I may, sorry. Do any other states do it this way? Are you aware of?
My understanding is that, yes, some other states are doing some similar things here.
Okay, and then I can look at that. And then,
yes.
Who were the stakeholders? You said the stakeholders were negotiated. What's the list?
Gosh.
And you can get that at the close.
Yeah.
If you could just say what the stakeholders are.
Okay.
All right.
Yeah, I can list that for you at the
Thank you.
conclusion. Sure.
Okay. Thank you. Appreciate it. I really do appreciate the issue. I really do.
Yeah, thank you so much.
Representative Schaffner.
Thank you. And thank you so much for this bill. It says on line 2021 that mental health facility, regardless of the person's age. So does that mean that below 18, there's no requirement to get the parent's consent, or?
I'm sorry, where are you reading from?
On the first page of line 20 and 21, the paramedic may detain, starting at 19, for preliminary examination under section blah, blah, at the mental health facility, regardless of the person's age.
Oh, that's not this committee substitute.
Oh, I'm so sorry.
So no, that's okay.
So does the committee substitute address that?
Yeah, this is, again, that's something I'm going to have one of the witnesses answer, if I could, please.
Yes.
Thank you for that.
Thank you.
Okay.
Oh, and I can ask, well, for instance, in rural Texas, obviously, the mental health facility is, like you said, stated about the sheriff's, hours and hours away. So the paramedic's willing to drive the hours and hours away as well, taking.
Yes, I'll give you an example of what was presented to me by Scott Rubin, who's going to be one of the people testifying, when he first brought this to my attention. In a rural community where you have limited law enforcement and they have to go for hours to do this transport, if it is a community paramedic in their county, they actually have someone who is not part of the ambulance, but actually drives around an Explorer and visits with folks who have crises on a regular basis in their community. It would be that person who would drive them to the facility so that you would still have your ambulance present, you would still have your law enforcement present. That's one community, and they may not all work that way.
Sure.
But the idea is to try to use the resources in such a way that you still have what you need in your own home community to deliver the necessary public health and public safety services.
All right, thank you.
Mm-hmm.
Okay. Thank you. We will reserve your
Thank you.
opportunity to close. Chair calls Tim Stevenson, Lee Spiller, Thomas Maya, and Angela Ott. Members, we do have resource witnesses from DSHS. If you have questions and would like us to call that resource witness. So I show Dr. Tim Stevenson. Thank you. Well, I called our resource witness, actually. I'm sorry, but Department of State Health Services neutral on House Bill 1656. Is that correct?
Yes, sir. Here if there are questions.
Okay. Members, any questions for DSHS at this time? Okay, thank you. Chair recognizes Lee Spiller, Executive Director of Citizens Commission on Human Rights, against House Bill 1656. Is that correct?
Yes, sir.
Okay, proceed.
Thank you. My name is Lee Spiller. I'm with the Citizens Commission on Human Rights, Texas, and we're against the bill. To us, this bill is tailor-made for fraud and rights abuses. If someone is a danger, you want the police there, and the police should be making that call. So we can only assume that this bill leans towards the detention of non-dangerous individuals. That's a slippery slope. In my written, you will see we've already had problems with private ambulance companies committing fraud. In the Houston area, there was a situation where you had these mental health day treatment programs, and apparently people were being transported in ambulances back and forth between the day treatment programs and the group homes. But according to the Chronicle and the feds, they didn't really need ambulance transport. That's huge money. The committee sub, as I read it, and I don't have it with me, also applied to private ambulance companies. So now you have somebody with a financial stake in the ride. If law enforcement needs mental health professionals that they can consult with in cases where they have questions, then they should have people they can consult with. But we should not grant police powers to EMS. It's a distinct situation, and the other concern is if we're doing it with ambulance people, how are they going to restrain these people? All right, so we're talking about physical restraints, chemical restraints, and those are dangerous. So we would much rather see law enforcement have the advice when they need it than we would ambulance people detaining people. Also, a lot of cities have, we changed the law, I can't remember which session, where cities can enter into agreements with their EMS to do the transport. The law enforcement person still does the detention, but the ambulance does the transport. There's nothing to stop people from doing that now.
Okay, thank you.
Thank you.
Chair recognizes Thomas Maya, paramedic and registered nurse, testifying on behalf of Hayes County EMS Association and yourself, and you're for House Bill 1656. Is that correct?
Yes, sir.
Thank you. Proceed.
Good morning, Chairman Van Dever, members of the committee. My name is Tom Maya, and I'm a member of the Hayes County EMS Association, an employees union representing paramedics in the Hayes County area. I also work as a pediatric nurse here in Austin. I'd like to speak in favor of House Bill 1656 with the hopes that it will open the doors for better care for individuals experiencing mental health crisis, fewer barriers and costs for connecting them to the right resources, fewer burdens on law enforcement, and the potential for better relations between law enforcement and vulnerable members of our community. There are many such cases in which a paramedic may be the more appropriate first responder to initiate an EDO over a law enforcement officer. A neighbor with an episode of acute psychosis who is walking half naked down a residential street. An unattended teenager who is jumping in front of vehicles in a busy parking lot while experiencing family strife at home. A gentleman struggling with an overdose of stimulants who is in a state of paranoia. A nursing home resident with acute dementia who is being aggressive with staff. These are all cases that I've personally attended to, and there are many near identical cases, each with their own idiosyncrasies that my coworkers have attended to as well. And these are cases that change when someone is armed. Obviously, we need law enforcement running point on those cases, but in all of the examples I listed, very common. These individuals are unarmed and in extremely vulnerable states. And yet with all of them, I couldn't get them connected to the care of a physician, psychiatrist, or the right resources unless a police officer placed them on an EDO, sometimes threatening with arrest or charging them with public intoxication or disorderly conduct. I believe that we can have cases where EMS providers, specifically paramedics, run as the primary without heaping additional tasks on law enforcement, without adding escalation. Myself and many of my peers in paramedicine also hope this bill opens up a conversation for increased funding for mental health care and EMS in the state. Several big city departments have room in their budgets to run community paramedic programs, for example, many of which emphasize care for citizens with mental health conditions.
Thank you for your testimony.
Mhm.
Chair recognizes Angela Ott, testifying on behalf of Disability Rights Texas against House Bill 1656. Is that correct?
Yes, that's correct.
Thank you. Proceed.
All right, good morning, Chair Van Dever, Vice Chair Campos, and members of the committee. Thank you for the opportunity to testify this morning regarding our concerns with HB 1656. While this bill does truly intend to improve our existing mental health crisis, giving licensed paramedics and EMTs the legal authority to initiate warrantless emergency detentions is a step in the wrong direction. If we increase the number of professionals that can initiate detentions, we will truly see an increase in the number of detentions in our state and an overburdened mental health system that will not be able to accommodate the increase of individuals in involuntary care. The stated intention of this bill is to provide medically driven, compassionate care to individuals in crisis, which is important, but emergency detention is intended solely as a temporary measure to mitigate immediate risks, not to provide mental health treatment. The current public perception of paramedics is typically one of trust, but enlisting paramedics to initiate detentions will likely have a chilling effect on individuals with mental illness interacting with EMS in an emergency due to fear of detention. Many people with mental illness are already fearful of involuntary commitment or detention and avoid seeking care due to this fear. We're extremely concerned that this bill allows paramedics employed by private facilities to initiate detention and bring an individual back to the facility they may be employed or contracted by. In light of recent multi-million-dollar fraud and abuse cases in private psychiatric facilities, this bill could unknowingly incentivize more fraud and abuse of individuals with disabilities and of taxpayer dollars. Finally, alleviating strain on law enforcement is a valid concern, but Section 573.005 of the Health and Safety Code allows law enforcement and EMS to enter into an MOU, to alleviate transportation burden on law enforcement. Rather than make a drastic change to the emergency detention system, we should carefully examine why our current systems are not working for us. While HB 1656 intends to help individuals in crisis, enacting this policy will likely worsen existing problems in our system and will fail to address the root causes of these problems. Thank you.
Okay, thank you. Members' questions. Representative Collier.
Thank you, Mr. Chairman. I don't know who can answer this question, but would the police still be deployed on a call that's under this provision, under these provisions? Would the police still come out?
Go ahead.
The way we read it, they wouldn't have to be.
Well, I mean, if you call 911, they say, 911, what's your emergency? And my family member's in crisis. Okay. Send only EMS?
I don't know. I mean, that's the problem. The bill doesn't lay it out specifically enough. You may have better answers.
I can speak to that from personal experience. As far as a dispatching issue, both law enforcement and EMS still respond to those calls very routinely. So this doesn't reduce the number of units that say respond, but it provides an opportunity for someone with medical training to run as the primary responder on that call. If that individual, for example, is armed, that obviously changes things, but it does not mean that law enforcement does not respond to these cases at all.
Okay. So if you said something about primary. So if this bill is implemented and the, I guess it's the paramedic or
The paramedic.
paramedic determines that, oh, they're in crisis, police, let us handle it. And then the police witnesses an assault. Who trumps then?
So in this case, the police witness an assault committed by the individual in crisis?
They're
or
in crisis. I mean,
if they physically assault a person, that is now primarily a law enforcement issue. Again, everyone's safety is paramount. But there are many cases where an individual experiencing a psychotic episode has not broken the law. There's concern for their personal safety, but they're not themselves a suspect. That's what this bill is supposed to address.
well, I'm all for that. It's because to me, if they're in crisis, they're not able to make, sound judgment calls, right? My concern is that when law enforcement sees that and they don't have the same training as the person, the paramedic who's going to take this training, they may disagree. I just want to make sure it's clear on who can make the final call on whether this remains civil or, helping them getting the help that they need, or does it turn into a criminal action? I just want to make sure that we're clear on it, and I don't know how it works
course.
in Hayes County, but what happens if somebody's in crisis?
If someone is in crisis and they break the law, then obviously law enforcement still needs to be involved. But especially if they were to, if they were credibly accused of assaulting another person, my understanding from this bill is that it does not take away detention authority from law enforcement, but in certain cases where it overburdens a law enforcement officer to get someone the care they need, a paramedic crew can initiate that detention order for purposes of getting them to the care of a psychiatrist.
So my problem is I've had this happen in my district where someone was in crisis and the officer witnessed. The person should have went to the hospital. Instead, they went to jail.
Exactly.
So I'm not sure if this, fixes that, or if there is a fix. But I'm concerned that it won't help these cases. I mean, it's still going to be the same outcome. They'll go to jail when they need to go to the hospital. If we don't clarify, what happens. My other question deals with the emergency detention order. So we're going to allow paramedics to have an emergency detention order authority. How long does that last? And is there authority through while they're on site, or does it last where they transport them somewhere and they can continue to have the ability to detain them if they're not on site at the original call?
As I understand it, this would start with initiation of the order on scene through continuum of care, transporting that patient to the ER of a full-service hospital or a mental health facility that can accept EMS transports. As for the first part of your question, I would emphasize the ability of clinicians or I guess the training of clinicians in matters of de-escalation, crisis intervention, establishing a therapeutic rapport that not all police officers have. There are certainly designated mental health officers in many parts of the state, but not every police department has one of those.
Yeah, we have some in my area, but we just don't have enough.
Correct.
We don't have enough. And so I like the concept. I just want to make sure that we're not overstepping and that we're
Certainly.
actually answering the needs of what is involved in the community, what actually happens.
Yeah. And I would emphasize that above all things, as healthcare providers, we have a duty to our patients first and providing patient-centered care. So this is not about detaining individuals unnecessarily or making them do something against their will. This is about connecting them with definitive care, with the right resources, which if you're getting a person charged with, for example, public intoxication, disrupting the peace, or taking them to jail, none of that is definitive care. None of that is care at all.
Mm-hmm. And based on your understanding of the bill, it's voluntary, like an entity would not have to implement this bill if they didn't want to. Like in my area, the firefighters are now the paramedic. They, primarily doing it for the city of Fort Worth. If they decide not to do it, they don't have to do it. If they're not ready at this time, they would
Correct.
have more time.
This bill is not like a one-size-fits-all policy.
Okay, thanks.
Representative Jones.
Oh, I'll just start off by saying I think the road to hell is paved with good intentions. I really don't know that I have questions. I mean, someone can chime in if you want, but let me just tell my concerns, and then somebody can respond. One, I believe that this is a violation of the Fourth Amendment, especially if the government is authorizing this, which concerns me, which is the right to be free from illegal search and seizure, which necessarily includes detention. I'm concerned about private ambulance companies profiting from detaining people. I'm concerned about due process. My concern is, so some random person who doesn't know you, paramedics, think that you're in a mental crisis, and maybe you are. They get to decide what's best for you. Then, if I am having a mental crisis and I didn't want to go to a facility, who can I sue? I mean, under the Texas Tort Claims Act, government sanctioned employed paramedics are immune from being sued. At least if there's a warrant, somebody can go get it. It just seems like with this bill, that if someone determines that you're mentally ill, that you lose your constitutional rights.
Yes, I would actually like to address that if you don't mind.
Yes, sir.
Yeah, we've always had due process concerns with detentions because it's 48 hours of which you've been deprived of your liberty. If it expires over the weekend or on a holiday, then it moves to the next business day. Then, if they want to keep you, they can keep you for another 72 hours under an application for an order of protective custody. And only after that 72-hour mark does the judge have to find probable cause. You can be transported. You have to be examined within 12 hours, but you don't have to be informed that what you say to a mental health professional can get you further detained for 24 hours. So you have no constructive Miranda.
So where's the lawyer? Is
Correct.
what I would think. But I'll say this, so for example, in Harris County, we don't have enough mental health facilities. We just don't, right? So, and I'm a criminal defense lawyer, so I will have clients, but they should have been diverted, right? But there was no place for them to be diverted to.
Yep. We would like to
So-
see more voluntary, including
And
respite.
And so I also think that this is America, and this is Texas, and capitalism is the name of the game. I can see a bunch of pop-up mental health facilities come up that say, hey, we're qualified to deal with your mental health issues. Because if you build it, they will deliver them, which is a play on if you build it, they will come. So I'm just concerned about civil liberties and who gets to decide if I'm having a mental health crisis. And then am I responsible to pay for it if you put me there?
Right, and what if you are having a crisis? Are you dangerous, right? If you look at O'Connor versus Donaldson, the situation in which a state can detain you is pretty narrow. But we keep moving over into the person's in crisis, or the example the judge gave on an earlier bill, this anosognosia thing. You don't believe that you're mentally ill, therefore you're mentally ill. Right, we're on a slippery slope here, and we really need to be careful.
And I'll just end with this. I heard, I know you're an RN and I think a paramedic. So I guess my consternation is that we will take examples like you gave, a kid jumping in the parking lot in front of cars, or I remember the examples that you gave, that we take something like that and it's obvious that maybe the kid was suicidal, I don't know. Those kinds of examples to overlay onto every mental health crisis situation. So I agree that there are people who should be, sometimes mental illness but if you're beating up a cop, but you don't know you're beating up a cop, should you go to a mental health facility or should you go to jail? So you see so everything is not so simple. Do you understand what I'm saying?
Again, cases like assault or someone who's being an active threat to themselves or others, law enforcement is still like the primary role player in those kinds of incidents. I would simply emphasize on some of your consternations that EMS and law enforcement together, in my personal experience, are already responding together to these kinds of calls. And in a lot of these cases, as long as they haven't been charged with the crime, EMS is still often transporting these patients to the ER of a hospital. In cases, especially where the appropriate facility is a county away or several counties away, we then have to coordinate with law enforcement as to, okay, we've determined that this individual cannot be left to their own devices. That's part of, my job as a clinician, by the way, because if I was a law enforcement officer, I'm looking mostly just in pure terms of physical safety. As a paramedic, I am trying to get a list of this patient's allergies, what medications they're on, have their medications been changed recently. That's part of my assessment as a responsibility to that individual. But in many of these cases, both EMS and law enforcement are already involved in the scene. If we determine that the individual needs to be transported somewhere where they can be evaluated by a physician, and we've determined that they cannot be left alone, but they haven't technically broken the law, how do we then connect them to the resources that they need? And that's what this bill is meant to address.
So, and I understand, but you're an RN, and
I am.
and you're a paramedic, which most paramedics I know aren't RNs.
Okay.
Right? Do you have some kind of special training or
No, I work
something?
full-time as a nurse now, but I still work part-time as a paramedic. So most of my input on this bill is from my previous experience in EMS.
I mean,
But I've seen both sides of the issue. I've seen both. I've received patients like this, and I've transported patients like this.
I'm just, anyway, again, I have consternation, but thank you.
Representative Schaffner.
Thank you. Mr. Maya,
Yes, ma'am.
so who would be paying your bill? Would it be the county? Would it be the individual to transport the
When
patient?
you say my bill,
Or
it
the
implies
bill.
that I get
bill.
some kind of kickback for transporting an
Not
individual. I
kickback,
don't.
but you have, I mean, it has to be paid,
Mhm.
right? So who are you billing? Who would the paramedics be billing?
That depends. I mean, many of these individuals are recipients of indigent care. Obviously, with every kind of service provided, there is a bill. There may or may not be a transport bill. There often is a hospital bill. People don't necessarily ask to be transported to the hospital against their will, but in cases of someone experiencing an acute psychotic episode, the other alternatives are them being arrested and put in jail, or left to their, just being left on the scene, and that's not appropriate either. So I'm not saying that there's perfect solutions to all of these, but I am saying that I would trust that individual in the care of a licensed health professional, definitive care being the psychiatric team to which that individual needs to be devoted. But as a paramedic, I make the same amount of money per hour, whether I'm doing nothing, transporting a patient who needs minimal services, talking to a patient who refuses to go to the hospital and meets criteria to refuse, or in this case, a patient who needs inpatient mental health treatment, but is refusing to go or does not meet the clinical capacity to refuse care.
So the paramedic company would be billing the county, the
It
state?
depends. So EMS is kind of a hodgepodge of different structures in the state. There are private for-profit EMS services, there are private nonprofit EMS services, there are municipal county services, and then there are city departments. So I'm not going to sit here and tell you that this bill is appropriate for all services. That's why it's voluntary.
And if there's a or what percentage of the incidences that you stated earlier, or in general, are alcohol and drug-induced mental psychosis situations?
Percentage-wise, I would not be able to tell you off the top of my head. But
guess.
if it's drug-induced, then it would depend on is that individual a repeat case in the county that we're responding to, or whether in that moment they are a threat to themselves or others. I think we can all agree that someone who's experiencing a mental health crisis due to an overdose of stimulants is not necessarily is a patient first, and not primarily an offender.
So would restraints be necessary in that situation?
In some cases, yes. Apart from someone being handcuffed and thrown in the back of a PD unit, in an ambulance we have soft restraints, and in acute cases there are chemical restraints, but we have protocols. A patient needs to be, if we're going to give a chemical restraint, of a medication, they need to be put on monitors. We need to be aware of what their history is, what their medical allergies are. Again, that's patient-centered care.
And wouldn't time also be needed in order for either the drugs or the alcohol to wear off? Just a safe place for time? I mean,
Yes.
so that can be anywhere.
Correct.
I mean, it could be in a jail, it could be in a mental health facility, it could be in a hospital, could be at home in bed.
I would say if someone's experiencing side effects from acute overdose of a substance or a medication, then that person should be in a place where they're getting continuous medical monitoring.
Sure. And so, in the committee substitute, line 27, it also says, regardless of a person's age. So are you able to do this with someone who's 15 or 14 or?
I can actually give a really good example that my 2-minute testimony alluded to. I was dealing with an unattended teenager who was having an episode, did not technically endorse suicidal ideation, but was jumping in front of cars in a busy parking lot, had left her shift at a local fast food restaurant, and, we were concerned for her personal safety. The nearest appropriate facility for her to get evaluated at was in another county completely. And in conferring with the local sheriff's office, they were saying, well, the easiest thing is for us to put her on an EDO, you take her to an adult facility here in this county, and then we confer with the sheriff's office of the adjoining county, and then we hopscotch until we get to that pediatric facility. That's onerous, that takes time, that is a lot of burden on the system. There's easier ways to accomplish that, and she's still getting transported anyway. She still can't be left to her own devices, and at the same time, her parent is still very much a part of the equation. So I know someone brought up concerns about detaining a pediatric individual or someone under the age of 18, but this does not mean that we don't involve parents either.
So is there a requirement to involve parents? Were you, in this situation, you obviously called the parent at some time, or there's no requirement to?
Informed consent is obviously the gold standard. In that case, I was able to get in touch with this person's mother and was able to get her on board with the plan of care and transported by us in a way that was nonviolent, de-escalated, no restraints needed. And then her mother came with us to the ER, the place that I transported her to. The alternative would have, for her to have been placed under emergency detention. Again, this was not me placing her under detention, but the alternative was, an EDO by the police.
So, but it's not required, you're not required to contact the parent to get consent?
Yes, so I am, but in the event, in that case, it took some time, but I was able to get in touch with the patient's mother.
I know in that case, but just in general.
At this time, if you are taking care of a pediatric patient and you cannot find their parent, it is still your responsibility to provide care to that patient. So no, but you do your best to get informed consent from that patient's parent.
Okay, back to the billing. So, for instance, if you go to a different county, because in rural counties, obviously, you might have to go through 3 counties or 3 counties away.
Certainly.
So the further away, would the paramedic company, charge more for that? Just practical matters. I'm not accusing or anything like that, but just practically, distance, mileage, as well as getting, do the county share the costs? Since it's originated in one,
I'm not a
but-
billing expert. I know mileage is accounted for just for purposes of gas,
Sure,
but
right.
I'll have to defer to someone else on that.
Okay, great. Thank you so much.
Vice Chair Campos.
So thank you for your testimony, Thomas. And I'm kind of torn on this because we definitely don't want to overload the paramedics and the firefighters. But at the same token, I kind of like the bill, and I wish there was a way that y'all could work together with the author and make something happen. I know someone personally that has mental illness, schizophrenic, rheumatoid arthritis, lupus, epilepsy. She went in for an ED, went to the hospital, was released, and 3 days later she had another episode, and her husband called the PD because he didn't know what to do with her, and he made it very clear to them that she was having another ED and she needed to go to the hospital. Well, they took her in. At that point, they pressed charges on her for assault. So she was in the jail, didn't get treated for 5 days. By the time she came out of jail, she was black and blue in the face because she was hurting herself against the wall and what have you. She gets out of the hospital, has to go to court. Now they're going to revoke her. I mean, it's just on and on and on. So I'm kind of torn on it, and I wish there was a way that we could come to a solution.
If I may, can you, if you have any details on how she got the felony, do you know in what?
Because she hit her husband.
Oh, okay.
But the husband told the officer, listen, she's just having an episode. Like, she just got out of the hospital. I need to get her to get her care and get her back on her medication because she had been off her medication.
Yeah.
So, you know, it's a touchy situation. And then, of course, we don't have enough facilities for them, and it goes on and on. So it's a lot bigger than this, but I really wish that there was a way that we could work together because there's so many individuals that are homeless, that are mentally ill. Like you said, you see them unclothed, walking, you know, and they're deteriorating right before our eyes.
And you
So
said this person went to jail instead of a hospital?
she went to jail, and she was in jail for quite some time. And when she got out, she was in really bad shape. And now she's on probation, which she's revoked. So now she's got a warrant. So now she's just stuck in the system, and her issues are worse.
I would just add in closing that if we want to protect people's rights and get them the best care that they actually need, you know, this is an opportunity for us to potentially give some of this authority to EMS as appropriate to prevent situations like what happened to this loved one of yours.
Right, but again, we don't want to put all the authority on them because, you know, it's touchy, right? So I just wish there was a way that we could, you know, work on this and make things better for the ones in need.
Which is why it's not a one-size-fits-all bill. It's a
Of course.
voluntary bill.
Yeah, and I did want to say as well, I asked about the felony just because under current law, there was a bill passed last session where, again, it was a good intention bill, but you can pick up felony charges while you're under an EDO in a hospital, and it does happen, and we have cases where people are sent straight to jail after they're discharged, and they deteriorate. So I think we have to be really mindful about making huge changes like this.
Thank you.
Representative Jones.
Just one final question to you. You said at least 2 times it's not a mandatory bill, but it's voluntary, and then you just said it's not a one-size-fits-all bill. That's why you're voluntary. I mean, so here's my question: it's voluntary by who?
So because EMS is run so differently in different parts of the state, you've got some big city departments that have their own established community paramedic programs, many of which are emphasize mental health response. I would say that, you know, giving detention authority to a paramedic is not appropriate in every single part of the state.
So hold on, I'm gonna cut to the chase.
Okay.
It's voluntary on whose part? It's like is it?
On the part of cities and municipalities to adopt.
So it's not voluntary on my part, the person that's being detained?
I would simply point out that a lot of these times when the 911 call goes out, EMS units and law enforcement units are already responding to that situation. So these are already cases in which things have escalated past a certain point.
I'm gonna ask you one more time. It's not voluntary on the person who's being potentially detained. Is that inaccurate?
That is correct, but it's not voluntary now.
I don't know if you know this, but in my day job, I'm a lawyer.
Yes, ma'am.
And I deal with clients who have mental illness and they're in the jails.
Yes, ma'am.
So my point is, since you didn't seem to get it, is that I think it should be voluntary on the person whose constitutional rights are being abrogated.
Correct.
Just giving me flashbacks to like times I've read in American history and world history where there's a police state
I would not say that this bill solves that issue on its own. What this bill provides is an opportunity for that person to be cared for primarily by a clinician who practices patient-centered care.
I think we all want the same thing.
Mhm.
I'm just not certain that this bill is a vehicle to get us there. Well, I did not intend for that to be a pun, but it appears that it is. But thank you.
All right. Thank you for your testimony.
Thank you.
Chair calls Courtney Harvey, C.J. Grisham, Michael Bullock, and Christine Bussey. Members, it is the chair's intention to recess at about 10 minutes to 11, so we will have time to get to the floor to check in. So keep that in mind. Chair recognizes Courtney Harvey, Associate Commissioner of the Office of Mental Health, Health and Human Services Commission, resource witness, neutral on House Bill 1656. Is that correct?
That is correct. Thank you, Chair Van Dever.
Okay. Members, any questions for Ms. Harvey? Okay. Chair recognizes Christine Bussey, testifying on behalf of your peer policy fellow, testifying on behalf of NAMI, Texas, for House Bill 1656. Is that correct?
Yes, thank you.
Okay, thank you. You may proceed.
Good morning, committee members. My name is Christine Bussey. I'm here representing NAMI Texas, the state affiliate of the National Alliance on Mental Illness, testifying in support of Committee Substitute House Bill 1656 by Representative Howard. NAMI Texas supports efforts to create more medically driven responses to mental health crises. This bill authorizes trained EMS medical directors and paramedics they delegate the authority to initiate emergency detention when someone is experiencing severe emotional distress and deterioration, including when a person cannot recognize their own symptoms or appreciate the risks and benefits of treatment. Our support comes directly from the families' experiences navigating mental health emergencies, who often report loved ones in crisis unable to receive timely care. This bill enables trained medical professionals to recognize when someone is experiencing severe distress and provide a medical pathway to evaluation before crisis escalate further. While some communities have established co-responder models, many, particularly in rural communities, lack these resources. In these settings, trained paramedic may be the only appropriate professional available, allowing a person in crisis to be met with medical care rather than only a law enforcement response. For many families and individuals living with serious mental illness, lack of insight or the ability to recognize one's illness presents a significant challenge. This bill recognizes this clinical reality and provides a compassionate pathway to care when individuals cannot recognize their need for help. We thank Chair Howard for her leadership on this bill and the opportunity to work with her office to strengthen it, and we respectfully urge your support of Committee Substitute House Bill 1656. Thank you.
Thank you. Chair recognizes C.J. Grisham, Dr. C.J. Grisham, testifying on behalf of Texas Gun Rights and Self against House Bill 1656. Is that correct?
Yes, Chair.
Okay, thank you.
So like, we are opposed to this bill. My name is C.J. Grisham. I represent Texas Gun Rights, and on behalf of our members, the main issue we have, among many, Ms. Jones brought up probably everything we were going to bring up, so I can focus on other issues because we share all of her concerns, and I do as a criminal defense and civil rights attorney, that when somebody is involuntarily committed, they lose their gun rights. You throw somebody in that cage, they lose their gun rights. And now what we're saying is that a medical or an EMS person or a medical director who is not in the government can just say, okay, you're going in a cage. Now, keep in mind, this isn't limited. You heard all the testimony in favor of this bill that, when we go on a call, this isn't limited. This doesn't say just when you're on a call. If some EMS professional just sees a guy at Walmart and he thinks that person is, psycho, by this bill, he can just throw him in a cage.
And here's the thing, you think escalation's a problem now with police, and you're an EMS person, you try to detain me? Yeah, I'm fighting you. There's gonna be some escalation. You're not throwing me in a cage, you're not detaining me, you got no authority. And we're giving civilians this authority to do that. Now, one of the things that's kind of interesting is in the training, it says that they're supposed to be trained on the right to self-defense. I sure hope so, because they're gonna see some self-defense when they try to get me. You know, we live in a society right now where under this standard, you know, Biden and Trump can both be thrown in. You know, EMS can, when they come here to speak, some EMS person can say both of you are mentally incompetent and throw them in a cage. I've had 2 patients that I've had to remove who were thrown in there who never should have been in this hospital up in Tarrant County. And I show up, and we talk about attorneys. When I show up because they've hired me, and they say, "Oh no, we've got an in-house attorney." No. I'm the attorney. Well, we have an in-house attorney. No, I'm the attorney. And that in-house attorney hasn't even talked with this person, and we're going to a hearing on whether or not they can keep him for another 3 days. There's no due process here.
Thank you for your testimony. Chair recognizes Michael Bullock, testifying as president of the Austin Police Association for House Bill 1656. Is that correct?
Yes, sir.
Thank you.
Yes, sir. Again, Michael Bullock. I am the president for the Austin Police Association and an officer with the Austin Police Department for about 8 years, and during that time I have served as a mental health officer. I'd like to try to give you a different perspective in this. Not so much that law enforcement authority is being expanded, but rather medical authority has been placed upon law enforcement. We are not medical professionals. We have never claimed to be, but yet we have been told you have the responsibility of addressing mental health crisis. And we talk about mental health a lot and a lot of the stigma that surrounds it. It is not a criminal justice issue. I certainly recognize a lot of the concerns that people have about rights and about due process. But at the end of the day, we're talking about people who are dealing with a very cruel disease that removes their mental capacity to make rational decisions and often requires someone to intervene on their behalf. And that is being placed upon law enforcement right now. And officers, from the officer perspective, are being placed in an unwinnable scenario where we are expected to be mental health experts. We are expected to enforce mental health evaluations upon people and to use force if necessary. And yet we also have officers that when they do that and they follow their training and they follow best practices within the law enforcement community, they wind up getting charged criminally for their actions because the community does not like what they did. So officers are being placed in increasingly dangerous situations, are given very little protection when they're charged with dealing with this issue, and yet we're the primary responders for this. We do co-respond here in Austin with EMS, and we do so very well and very collaboratively. But at the end of the day, we are still law enforcement, and we deal with public safety issues. There's nothing in this bill that prohibits those responses. We are still responsible for assisting EMS when asked, and we are still responsible for working with them. But at the end of the day, if this really is a mental health crisis, why is law enforcement handling it?
Thank you for your testimony. Members' questions for this panel? Representative Schaffner.
Well, to answer your question about law enforcement, I mean, your job is to protect the community, obviously, right? And so you already have this relationship with EMS. So how is this bill going to change that, help that, in your opinion?
So I'll give you at least one example. I can go through numerous ones, but some ones that are very stark to me is if EMS gets a call about someone who is overdosing and they left a suicide note, that's an individual who's incapacitated. That is an individual who is experiencing a health crisis on multiple different fronts. So in order to ensure that person does get the treatment that they very clearly need, why does that necessitate a response from us when it really does fall only within the realm of medical personnel, right? So that's one example where, yes, we do have a public safety and we work with EMS, but what is the need to send an officer to that scenario if they're not an active threat to anybody else?
Who
Because
is sending you?
we're dispatched to these calls. All of these and all
Every
of these,
single one. Is it the fire department also?
In Austin, and I can obviously only
Right.
speak specifically to Austin, but we are a major city. In some cases, yes, but typically in Austin, it will either start as a 911 call that gets routed to EMS, and EMS will ask for us when necessary, and when that happens, we do respond, or they get routed primarily to the police department, and then we will be the primary responders and ask for EMS only if there's some sort of medical need or if they're requested.
Okay, so I'm still not understanding how is this bill going to be different for you?
Because right now, if EMS were to respond to that scene and they know there's like this person was experiencing a mental health crisis and they need to be on an emergency detention because they're attempting to end their own life by reason of that mental illness, they can't do anything about it. They have to contact us in order for that to actually happen. So we would still have to
EMS
respond.
going to someone who is, overdosed or overdosing cannot take that person and take them to the hospital.
They can take them to the hospital, but they would not, like, if they woke up and said, I'm going to walk back out and I'm going to go do the exact same thing, they have no ability to prevent that. They would have
The
to call
hospital.
us. The hospital, EMS, no medical personnel would have that ability if it was purely based on the mental health component.
But still, that individual be going into the ambulance, not be going in the back of your car,
Potentially,
potentially.
correct.
And would be taken to the hospital. And you're saying the hospital can't keep them.
Correct.
But but with this bill, the EMS person could take them to a mental facility where they could keep them.
They could take, yes, under this, they would have the ability to place them on an emergency detention, which would allow them to take them either if their medical condition would allow them to go directly to an inpatient facility, which would be the highest level of care for them, or if necessary, to an emergency room if they needed some sort of medical clearance, or depending upon where you are, like in Travis County, we designate emergency rooms as an actual appropriate mental health initial facility. They would have to be transported somewhere else beyond that, but they can be transported to an ER here in Travis County.
And for Austin, are you required, if it's a person under the age of 18, are you required to get informed consent?
As an officer, no.
Thank you.
Chairman Frank.
Just real quick comment. One, you said we're having increasingly dangerous situations, and then the bill hands it over to people who are not police officers, which I find interesting. But I think the biggest issue, and I hear it from everybody that has testified, is giving detention powers. You used an example that I think is interesting and maybe the only thing I could see this possibly being used for, which is a person who is literally passed out and it's a medical issue, and then you can maybe not have to send a police officer. When you have somebody and you are giving governmental detention powers, I mean, I just can't see any way to get there for it. And the last thing I'll say, and this will actually be a question, does an EMS personnel have any more mental health training than a police officer? I mean, you're primarily a medical personnel. You're not. You're the police officer, but they're not mental health professionals either. They're medical professionals, but they're not mental health professionals. So you're now putting somebody who is untrained in detention, untrained in physical restraints in that situation, and they're also not a mental health professional, and we're saying that's the person now that's going to decide and detain somebody because the police aren't trained to do it.
I think there's a few different things there to kind of unpack. I'll try to do so very briefly for you, but one of them is like they have a lot more medical training in dealing with conditions and diagnoses and medical evaluations overall, right? More so than what we do, obviously. It is a public safety concern where if someone is an actual threat, if they are presenting weapons, if they are presenting guns, things of that nature, that is still us. That's something that we need to go to, but that doesn't prevent a co-response where once we know a scene is safe, that instead of us being the one that is forcing an individual or transporting them or handcuffing them, we have other people who are more trained in medical care that may be able to gain more voluntary compliance that can provide better levels of care, maybe a better way to do it. But the other thing to consider in all of this is that there are cases, because we go to them all the time, where we are interacting with an individual and EMS believes that it is necessary to restrain them because they're going to have to go in the back of an ambulance and we're going to have to get them to the hospital. So there are instances where medical personnel can force individuals to go get medical care. And so we're dealing with a similar realm. I recognize that we're calling it a detention which means that we are forcibly making someone go to a hospital. But there are scenarios in which EMS has that authority as well for medical care purposes. So it's not this clear, bright line that exists in all of it. And a lot of it is going to require co-responses where police is there for the safety aspect, but the medical personnel can be there and have the authority to deal with the best medical decision once we know there's no longer a public safety threat.
Thank you, Chairman.
Okay, Representative Jones.
So I was looking at, so I know that with police, that under the Health and Safety Code 573.001, a peace officer may take an individual to a mental health facility for emergency detention without a warrant. If the following conditions are met, there's a belief of mental illness and risk, insufficient time for a warrant, and after they take them, they've got to, once in custody, again, the operative word is in custody, transport the individual immediately, provide notification, inform the individual why they're being detained. It seems like what this bill does, 1656, is it basically transfers the obligations that the police normally have to paramedics, and so I'm just concerned. So can you help me understand how that's, and look, mental health is cruel, it's tricky, and we wish we could do better as a society to accurately figure out how to deal with mental health, but I've got to balance that with the Constitution. So help me, President of the Austin PD Association, how this doesn't give paramedics rights that law enforcement normally has.
So it doesn't, it does authorize the same authority. It's not conveying, like taking away from PD and
But it's giving it to somebody who before now didn't have it.
Correct.
And doesn't have it.
Correct.
Okay.
But the other thing to consider too is that right now, as an officer, we have on an emergency detention, we're authorized through law to act on credible information from a third party. And oftentimes we go to facilities where I can go and I get called there. This has happened many a times where I get called to a emergency room. I get called to even an inpatient mental health facility for someone that may have gone voluntarily initially. And the psychologist, the clinician, they're all telling me, like they called us there and they said, this individual is experiencing a mental health crisis and they're wanting to leave now. And I can go and talk to that individual and get all of the information, and they can tell me how the individual is suicidal, they're doing all these other things, and I can go talk to the individual themselves and they can say the exact opposite or nothing at all. I'm still likely going to place that person on an emergency detention based solely upon the information that the medical providers have given me, because they are the medical experts and they're the ones that have seen things, whereas I have not seen what is going on. But a reasonable person would infer this is a crisis and this person would be a danger to themselves or someone else, which falls within the intent of the statute. So at times, medical professionals do have effectively the authority because we rely on them. When we're not present, we are relying upon them and their expertise. It's not a default, but we are relying upon them, and oftentimes it's only their word. So they kind of have that authority to a degree. It's just not authorized explicitly. And I know it's been brought up a lot about fraud or all these other issues that come up, but all of that is still illegal. There are still remedies per se. Even when it comes to gun rights, we can seize them, but it's very temporary. I've had plenty of people where we seize guns, weapons, and then 5 days later they get out and they go back and they get their gun.
So let me be clear. My concerns before is not because people were losing their gun rights. I just want to be clear on that.
Understood.
Clear, like crystal. So I want to go to the NAMI. I normally roll with NAMI. I do. How does NAMI balance constitutional rights or lack thereof or refusal to recognize thereof with this? I'm just trying to understand how y'all got there.
Sure. I'll answer that in twofold. I think The first reason is that this is a story that we hear time and time again from our NAMI members, is that their loved one is experiencing a crisis and they're unable to get to meet that criteria because they're not actively causing harm to to their family member or friends. And the way that we understand the bill is that a person must still be experiencing a crisis that endangers themselves or others, or deterioration so severe that they cannot remain safely at liberty. And so we understand this as a clarification of that part of it, more so than kind of the other thing that.
What's the other thing? To make sure, to see if we're talking about the same thing.
Sure, sure. I think that, the primary concern here is that someone experiencing a crisis is receiving the care that they need, and we see this as the best path forward to allow that to happen in a way that's medically driven, as opposed to only a law enforcement response to these mental health crises.
But if law enforcement can already do this, what clarification do we need? I just read the Health and Safety Code that allows law enforcement to do exactly what we're now trying to, what y'all are now trying to get the paramedics to do.
Sure, just that it's just clarifying that it can include as a part of the evidence that mental deterioration in ways. I don't have the bill language specifically in front of me, but I'd
Okay.
be happy to follow up
But,
and
but thank
talk
you.
more.
I appreciate your attempt to answer my question.
Okay.
Okay.
Okay, members, other questions? Okay, thank you for your testimony. All right, the committee sub is withdrawn temporarily. We're going to leave House Bill 1656 pending, and we will lay it out as pending business when we come back from recess, being recessed. Chair moves that the committee stands in recess until final adjournment or recess of the House or during bill referral if permission is granted. Is there objection? Hearing none, Committee on Public Health stands in recess.